So hello to all of you. Good evening to all of you, and I hope that everybody is doing well. So hello Sangeeta, Rohit, Dr. MS, Madhuri, Saddam. Hello to all of you, Penicillin, Krishna, Pramod, Deepak, Saddam. Good evening to all of you. So I can see, yes, Ajay Sharma, Joyce, Ritik, Arpit, Krishna, Arpit again, Divangan, Pranit, Beanie Boys, and Krishna. So good evening to all of you. So today we are going to discuss the most important questions of anatomy, and I hope that we do best with the anatomy subject, and we will try to deal with the best topics and the main topics of the anatomy, so that this duration of that time brings out a very good output for you, and it is very helpful to you for your exams also. So hello to all of you again. Thanks, Dr. Sneha. Though I cannot see you all, but I am feeling so good to see all your messages. And yes, keep the faith, keep working hard, and the great things will happen. It will definitely happen. Just the thing is that at present you have to keep faith in yourself, you have to believe in yourself, because this is a time when a lot of doubts come in our mind, a lot of things come in our mind, negativity, sometimes the negative vibes come in our mind. So what you have to do is that you have to maintain your calmness, you have to believe yourself. You have been studying so hard till now, and you have been putting so much of efforts till now. So now you cannot let it go in vain. And this is a time to keep that calmness and just focus on your revisions. Be away from any negative vibes. Like anything which gives you negative vibes, be away from it. तो इस टाइम पे कोई भी हम नेगेटिविटी को अपने लिए डिस्ट्रैक्शन नहीं क्रिएट करवा सकते, या फिर कोई भी नेगेटिव वाइब्स अगर है उसकी वजह से हम पढ़ाई करना नहीं छोड़ सकते. तो कोई भी ऐसी चीज़ जिससे आपको डिस्टर्बेंस हो रही है, आप उसको अवॉइड करो. थोड़ा सा आपको आइसोलेट होना है अपना, और अपनी पढ़ाई पे फोकस करना है. And a very important thing over here is that this is a winter time, as you know, 12 January exam date. It is a winter time, और सबसे बड़ा issue जो सबको आता है कि मैडम winters में नींद बड़ी आती है. So the thing is that for all of you, this is a suggestion that for a student, whenever you are studying, never study with that rajai on and on the bed. You have to study at table and chair. Sit on the chair and the table. Keep your book and then study. So that is the best thing you can do for yourself. अगर आप सोच रहे हो कि मैं बेड पे बैठा हूँ, रजाई कंबल ओढ़ के बैठा हूँ, तो नींद तो आएगी. तो that you have to avoid. Okay, now yes, 200 पार. तो इस बार 200 पार. Now let us start with this the questions, and now this is the first question. Now read it carefully and try to answer it. See, this is the first question I've kept over here, because the facial nerve is a very important topic, and if you see last 2 years, every time a question is coming, and we cannot leave this very important topic, and you should be able to deal with each and every question. If it is asked from facial nerve, it should be your scorer. फेशियल नर्व पे अगर क्वेश्चन आ रहा है तो कंफ्यूजन नहीं होनी चाहिए, आपका कंसेप्ट बिल्कुल क्लियर होना चाहिए. और ये वाला जो क्वेश्चन है हमारा स्कोरर होना चाहिए कि भाई ये क्वेश्चन आया तो आपको खुशी होनी चाहिए कि अरे यार फेशियल नर्व पे क्वेश्चन आ गया. सो नाउ let us try to do this question. Read the question carefully and try to answer it. ओके, ठंडे पानी से नहाना शुरू कर दिया. तो इससे पहले क्या गर्म पानी से नहा रहे थे गर्मियों में? बट दिस इज गुड. कोई भी तरीका जो आपको मतलब लगे कि it is useful for you, then it is good. The thing is that you have to focus on your study. नींद को दूर भगाना है, पढ़ाई पे फोकस करना है, वो मेन चीज़ है. अब आप किसी भी तरीके से उस चीज़ को कर रहे हो, कॉफ़ी वगैरह पी रहे हो या green tea पी रहे हो, because like coffee, if you are taking coffee a lot, you know it creates a lot of acidity. So preferably take green tea more, herbal tea more. Okay, so I can see yes, D, C, A, but a lot of students have answered D. Yes, very correct. The answer over here is D. Now let us see how to approach the question. Now over here what it is saying is that inability to close the eyes, as well as there is loss of transverse wrinkles. Now, when you see this point, you are very much clear that it is a element lesion and this is Bell's palsy. But now, along with it, what you see is there is also hyperacusis, loss of taste sensation, where in entire two-thirds of tongue plus loss of lacrimation. And now let us first of all discuss and then we will again come back. So first of all, let us see this thing. The facial nerve, when it is beginning, you can see facial nucleus, then after that it crosses this foramen, internal acoustic meatus, it reaches the ear, and then it exits the ear by stylomastoid foramen, and then it reaches the face. Now within the ear, this is the portion which is within the ear, it is giving three branches, which is greater petrosal nerve and nerve to stapedius, as well as what? As well as the cauda tympani nerve. Now one more thing is there, when we are saying greater petrosal nerve, then at this location there is a ganglia which is present, which is a part of the facial nerve itself. And now what is this? This is geniculate ganglia, right? This structure is geniculate ganglia. So we have understood this whole pathway. And now when you talk about the lesion, this is, we are talking about the element Bell's palsy. Now if the injury, like just imagine if the injury is at stylomastoid foramen, so all the simple symptoms of the Bell's palsy will be there. All the symptoms of Bell's palsy will be present. But now if the lesion is slightly proximal, you can see proximal means more towards here. And if the lesion is at this point, it is also involving cauda tympani nerve. And if the cauda tympani nerve is involved, due to this, what is there? That loss of taste sensation at entire two-thirds of tongue is also seen. So along with the Bell's palsy symptom, this extra symptom will be seen. Now if I say that lesion goes more proximal, okay, more proximal means over here. Now what will happen? Both the branches will be affected because the lesion is over here, so this complete area is affected. So now one additional symptom along with the Bell's palsy, this symptom also plus hyperacusis also. Now another thing is, if I say lesion goes more proximal means at geniculate ganglia. So now when the lesion is at geniculate ganglia, what happens? Along with the Bell's palsy, you have the involvement of all the three nerves, and now this symptom also plus loss of lacrimation. Fine. So now we have understood that why the answer is over here geniculate ganglia, because now option A written is cauda tympani. If the cauda tympani nerve is affected, only one symptom will be seen, that is loss of taste sensation. So this will not be the answer. Option B is greater petrosal nerve. If this is affected, then only one symptom again, loss of lacrimation. And now if I say, like option C is what? Facial nerve injured at stylomastoid foramen, then what will happen? Bell's palsy symptom are present, but all these symptoms, they are not present because these branches are not affected. And the last option is facial nerve involved at geniculate ganglia. Then we say along with the Bell's palsy, all the symptoms are seen. So that is why when you see this question, now we say the answer is yes. The answer is D. Very correct. Very correct. The answer is D. Now because we are talking about facial nerve, we should be knowing each and every point about the facial nerve. If I say Bell's palsy, now all these are the symptoms of Bell's palsy, but now what are the most important symptom? One is loss of transverse wrinkles at forehead. So these are the symptoms which you should be knowing by sure. One is this, another is inability to close the eyes, which is also given the term as leg of Thelmos. Right, it is also given the term as leg of Thelmos. Another is angle of mouth, the symptom related to it. See, over here you should be knowing this statement properly, that angle of mouth is tilted down, where? On the same side of the lesion. And when you say what is happening on the normal side, normal means opposite side. So the angle of mouth is actually deviated upwards. So for example, if you see in this image, okay, if you see this image, this is the Bell's palsy side, this is the normal side. So if I see the Bell's palsy side, the angle of mouth is tilted down at the lesion side, at the side of the lesion. But when you see the normal side, the angle of the mouth is slightly deviated upwards. So this point you should be very well knowing, and you should be able to differentiate this point on the affected side plus normal side. So these are the most important symptom, and because we are discussing this, we know that LMN, which is Bell's palsy, it is actually what it is LMN lesion in which the ipsilateral whole half of the face is affected. And now if I say what happens in UMN, so yes, you should be knowing UMN is actually contralateral lower half of the face is affected. So now this is completely, we have discussed about the facial nerve palsy. Fine. Yes. Now, okay, we know the answer over here. Now, I'm going to give you one extra question over here regarding the facial nerve, because you know the facial nerve is so important. One extra question. So now you know how to go for facial nerve injury question. First you decide it is UMN or LMN. Then after that, in the LMN, see if any extra things, extra symptoms are mentioned, and accordingly you can tell the site of the lesion also, you can tell. And stylomastoid foramen, you have understood, if the lesion is there, then only the symptoms of Bell's palsy. You are saying, ma'am, is 5-year PYQ is enough? No, 5 years PYQ is not enough. You have to do more, you have to cover more content, because there are other questions which are asked from the concept also. You know, PYQs are just to understand that what type of pattern of the paper can it be, and to so that if any question is repeated, you ensure that it goes correct, because there is some percentage of questions which are always repeated. So those questions we cannot lose, but we should be prepared for more questions also, and for that, like usually the conceptual questions are there. Okay, yes, very correct, very correct. Okay, as I can see, yes. So everybody is saying B. Yes, very correct. Now see over here what is happening. The patient has undergone the parotidectomy, which is basically the surgery on the parotid gland. And over here, the facial nerve actually divides into 5 branches. How it divides into 5 branches? One is over here temporal, then over here zygomatic, over here buccal, and over here this is the margin of the mandible, so marginal mandibular, and towards the neck cervical. Okay, so 1, 2, 3, 4, 5. So there are 5 branches which are present over here, and if you see this image, you can see we have shown the division of facial nerve into these 5 branches, and it is supplying the muscles according to the area where it is going. ठीक है, जिस भी area की तरफ जा रही है तो वो वाली muscles को supply करेगी. And now if you see the question over here, there is drooping of angle of mouth. The angle of mouth drooping. So over here means a muscle which is present over here, it is affected, and at this location there is a marginal mandibular branch which is actually supplying which muscle? Depressor anguli oris. Depressor anguli oris means which depresses this angle of the mouth. So this muscle specifically is supplied by this branch, and in fact you can answer according to the direction where the branch is going. And yes, very, very correct all of you. The answer over here is marginal mandibular branch. Now let us come to the next question. Now when you see this epithelium, can you tell me this epithelium is present at what location? So first of all, you should be able to identify the epithelium, and then you can say the location over here. So now whenever the question is in front of you, try to attempt it. Don't worry if it is right or wrong. Okay, sometimes there may be a silly mistake, or sometimes you may go wrong, but this is the time when you can correct yourself. ठीक है, ये मत सोचो कि अरे मैं क्वेश्चन मार्क करूंगा तो कहीं गलत ना हो जाए, या बाकी लोग क्या कहेंगे, मेरे बाकी फ्रेंड्स क्या कहेंगे. नहीं, आपको ये सोचना है कि ये टाइम है कि अगर मैंने कोई गलती कर भी दी तो मैं उसको ठीक कर सकता हूँ, ताकि जब एग्जाम डे आएगा तो मेरे पास गलती का स्कोप नहीं हो. मतलब गलतियां करूँ ही नहीं, गलती का तो स्कोप होता ही नहीं उस समय, लेकिन गलतियां भी ना करूँ. Yes, yes, yes. Very correct, Hrithik, Aditya. Yes, Ankit, correct. Hrithik, yes, very correct. This is transitional epithelium. And now when you are talking about this transitional epithelium over here, so this is the transitional epithelium. What is a characteristic feature over here is the uppermost layer, which is having the shape of the cell is slightly different. And what is the shape of the cell? You can see over here, it is like this, which is, you can see, bean shaped appearance, and it is given specifically the term as umbrella shaped cell or facet cell. This is specifically found in urinary system, so that is why it is also given the term as urothelium. And these are the locations of this epithelium in which these two examples you must be knowing very well, ureter and urinary bladder. So if you see this image, this is a multiple layer, and when you see the multiple layer, towards the uppermost side you can see this cell which is the umbrella cell, and by this we identify transitional epithelium, and the answer of this question is ureter. Very correct, all of you. Yeah, umbrella shaped cell. So the answer is ureter. So very very correct. मुश्किल नहीं है कुछ दुनिया में, तू जरा हिम्मत तो कर, ख्वाब बदलेंगे हकीकत में, तू जरा कोशिश तो कर. और ये जो कोशिश वर्ड है ये बहुत ही इम्पॉर्टेंट होता है हमारी लाइफ में, क्योंकि होप छोड़ देना ये बड़ा आसान होता है. और यूजुअली जब भी कोई प्रॉब्लम आती है ना, या फिर हमें लगता है कि हम पढ़ रहे हैं हमें याद नहीं हो रहा है, या बहुत सारी चीज़ें हमने पढ़ ली है कुछ ठीक से रिकॉल नहीं कर पा रहे, तो हम बहुत जल्दी होप छोड़ देते हैं. बट टेल योरसेल्फ कि नहीं, फिर भी मैं कोशिश करूँगा, आई विल ट्राई. So rather than losing the hope, like this is very normal to lose the hope at this moment of time, because so many things you are studying, 19 subjects you are studying, but always tell yourself that I will try again. I will give it a try. So try again, and that day will definitely come when you will be shouting with your success. Okay, now let us come to this next question over here. The arrow marked structure, it arises from which part of the brain? First of all, you have to identify that what is this arrow marked structure. Now you can see over here, this is what it is, a radiological image of what? Sagittal section. Okay, this is the sagittal section of the brain. So let us see, first of all you try to identify Dear, you are saying that is doing 25 important question is enough for FMG. See, this is actually very, very enough for your quick revision. Like, I know that you must be already studying the whole of the anatomy, and the basic concepts must have been formed. But at this moment of time, this is just like a quick revision. So it will be very, very helpful. And because we are covering all the important topics, all the topics which we expect that can come up as a question. So this duration which we are doing the question, it is a very important session basically. Oh, very correct, very correct. So now there is a confusion between A and D. So what I will do is I will zoom the image. Okay, so now so that you are very much clear that what is this. Yes, Bhaskar, very correct. Fornix, you are very, very much correct. Now when you see this image, one structure is this, right? This is what? This is corpus callosum. This is a corpus callosum, C-shaped structure. But when you talk about this arrow marked structure over here, the arrow marked structure is this one, which is fornix. Very, very correct, all of you. This is the fornix. And let us see the question over here. The arrow marked structure means what? Yes, means fornix. It arises from which part of the brain? So we have to actually tell it arises from which part of the brain. And now over here, the answer of this question is this. So I can see there is a confusion between B and D. The answer of this question is, okay, many have confusion in C also, thalamus also. But the question is, it arises from. So over here it arises from hippocampus. So fornix की जब हम बात करेंगे तो ये fibers होते हैं जो hippocampus से arise होते हैं. When you see in this image, you may see that it is some nearby, or it is located near the corpus callosum. So in the location it is near corpus callosum, but it is not arising from corpus callosum. It is arising from some different structure which is hippocampus. So in the sagittal section, this is the fornix, and if the coronal section is asked, in the coronal section, the location of the fornix is this one. Okay, this is the location of the fornix. So in either of them, you should be able to identify that what is the location of fornix. So this is the fornix over here. And now when we are talking about the fornix, a very, very important point is fornix arises from where? Hippocampus. So one main thing is hippocampus. Now where it is going to mammillary body. Okay, so it is going to mammillary body but arising from hippocampus. And next, what happens from the mammillary body? Now it goes to thalamus, specifically which nucleus? Anterior nucleus. Yeah, very correct, Shehbaz. It is arising from hippocampus B, but it is going to A, means mammillary body. Now over here, this is actually given the term as a Pepper circuit, but if you ask me, ma'am, that which is the main point over here to memorize, then I will say the main point for you to memorize is the 3 points, these 3 points plus the location of fornix, which I have ticked over here. Means you should be knowing hippocampus, from here fornix begins, goes where? Mammillary body. After that it goes where? Thalamus, which nucleus? Anterior nucleus. So mostly the questions are focused in on these 3 structures. So you should be able to answer this. So over here we know the answer is hippocampus. So they can ask you the question like it is fornix arising from where, or they can ask you fornix is ending on what, or they can ask you that fornix further, when it is going to mammillary body, further it goes to which nucleus of thalamus? It is the anterior nucleus. So we are now able to answer all the questions which are related to this fornix. Now coming to this next question, yes, now you can see very important point. Okay, now first of all you try to read the question carefully and try to answer the question, see the image and try to identify the structure also. Over here I have given hint as a symptom, like the symptom is given over here, which is giving you some hint. But if by chance the symptom is not given and only the image is given, then also you should be able to identify. Yes, very correct, Bhaskar, Dr. Sam, Khushbu, Subhash, Puneet. Very correct. Shivani. So I'm not able to take the name of everybody, but the response you are giving, this is the best response and very, very good. Yes, very correct. See, yeah, it is integrated with this is actually all the majority of the questions we have taken up is a clinical integration question, because it will cover up the conceptual questions also, it will cover up the clinical questions also. So if any question, straightforward question is asked, then also you can ask, then also you can answer, and if integrated question is asked, then also you will be able to answer. Now the point is that fecal material comes out from umbilicus, and now whenever it is written, you know it is due to completely patent what? Vitreointestinal duct. The answer over here is this. But if I say the symptom is not given and if the image is given, now also you should be able to identify. So the arrow, if you see, this area is actually umbilicus. So initially the umbilicus is, umbilical cord is attached at this location, or we say this is the location of umbilicus, and there are actually 2 ducts over here, one above which is attached to the midgut. You can see this is the midgut portion, and this is what it is, vitreointestinal duct. It is a vitreointestinal duct, but you can see there is one more duct which is shown over here, and now this is what? This is allantois. This is the allantois, and the allantois, if you see, this duct is going where? Yes, it is going to the hindgut, and there are 2 things over here. So we have identified over here at this location, this one is vitline duct and the lower one is allantois, and there are 2 things over here. One is when the completely patent vitreointestinal duct is there, it leads to vitline fistula or the fecal fistula. What is the symptom over here? Fecal material or meconium comes out from umbilicus. But now if the symptom is changed, that urine or the fluid is dribbling from the umbilicus or it is coming from the umbilicus, this is what? It is completely patent allantois, which we give the term as urachal fistula. Yes, very, very correct. It is allantois. Okay, you want to know about the urachus over here? Urachus is, I will just quickly mention about it. Now, when you talk about allantois, it is a embryological structure, and now we say its adult remnant is given the term as urachus. Okay, its adult remnant is urachus. and this is also given the term as median. The word alphabet over here is AN, median umbilical ligament. Okay, this is actually, uricus is actually the adult remnant of allantois. Now, so now we have understood vitreointestinal duct. Let us come to the next question. And the next question is regarding the nerves. This question we cannot leave because a very important question. See, radial nerve question has come till now. The ulnar nerve question has also been asked till now, but still we are waiting for median nerve. So I have covered each and every aspect of the median nerve so that we are able to answer the question, and again the median nerve becomes a scorer for us. Now what I've seen is that usually a lot of students, they become confused in the nerve injuries. That they say कि ma'am nerve injuries को कैसे answer करें, muscles confused जाते हैं, nerve injury में deformities में confused जाते हैं. So now what you have to do is that you should be knowing, mainly over here we are going to discuss median nerve, ulnar and the radial. And whenever we are talking about these nerve injuries, first of all you should be knowing deformities for each nerve lesion. Secondly, you should be knowing the sensory loss area. And if you know the sensory loss area, it makes it more easier to answer. The question becomes more easier to answer. Yes, yes, yes. Okay, so A, B. Ajay Sharma, if it is medial, L, if L alphabet is there, that is the remnant of umbilical artery. Okay, umbilical artery remnant, which we have discussed in this journal embryology. So that medial umbilical ligament is different and this median umbilical ligament is different. So very, very correct. And there is a slight confusion, like RSR is saying that maybe A or B. So yes, the main confusion lies between A and B. So definitely you know that ulnar nerve is not the answer because it is already written ape thumb deformity, in which the thumb is adducted. Patient is unable to flex index and the middle finger, which is what? Benediction deformity. So we very well know it is the benediction hand deformity. And the sensory loss is present where? On the lateral aspect of what? The lateral aspect of the palm. So now over here, if you see, three options are related to median nerve. One is the high median nerve injury. Another is the low median nerve injury. Carpal tunnel syndrome is also involvement of median nerve towards the lower aspect. Now, before we try to rule it out, let us first of all quickly go through the median nerve. Now, when we are talking about the median nerve, we know that it is passing through this forearm, in which it is giving direct branches to muscles like pronator teres, flexor carpi radialis, and this palmaris longus, flexor digitorum superficialis. Over here, it gives a branch. Which branch? Anterior interosseous nerve, which is specifically supplying deep group. The deep group is this one. Now, another thing over here is, at this location, you can see the median nerve is passing deep to the flexor retinaculum. But if you see one of the branch shown over here, yes, this is a cutaneous branch, a branch which is given to the skin, which supplies lateral part of palm. Okay, it supplies the lateral part of arm, and the cutaneous branch which is given later on. The cutaneous branch which is given later on, it supplies lateral 3.5 fingers. So what I mean to say is that if I say lateral aspect of the palm, so the hand over here, so palm area is supplied by this nerve and the fingers area is supplied by this nerve. So the palm gets supply before the flexor retinaculum and fingers get supply after the flexor retinaculum. Okay, this point you should be knowing. Now let us go further. When you say high lesion, like high lesion means if you see lesion A at upper level, lesion B almost at the wrist. If I say lesion A, then we are having all the three deformities, benediction, which is this one, in which the patient is unable to flex this index and the middle finger. Also you have this ape thumb deformity where there is adduction of the thumb. Plus there is pointing index, which is also given the term as Ochsner clasp test. Along with it, thenar atrophy and sensory loss in the distribution of the median nerve. These are the symptoms in high median nerve injury. But when you say low median nerve injury, this is what? Low median nerve injury, which is almost at the wrist level, and now the symptoms have reduced along with the sensory loss. Mainly the deformity seen is ape thumb deformity. Okay, mainly it is ape thumb deformity. Benediction deformity is not there. Plus, whatever sensory loss is there, it will be mainly towards the fingers area, because the palm area has already got the supply. So now this thing we have understood, and we should be knowing about the sensory supply also, that median nerve is supplying this lateral 3.5 towards the palm, rest, ulnar nerve, and for the posterior side we say ulnar nerve area remains the same, but median nerve only supplies nail beds. The rest of the area is by radial nerve. So this is the sensory supply which you should be perfectly knowing. And now let us come back to the question. Now when you say in this question, all the symptoms are according to the high median nerve injury, means the ape thumb deformity plus the benediction hand and sensory loss. The sensory loss, if you see, it can be like we have written it is towards the palm area. But when you say low median nerve, then the ape thumb deformity, it suits. But there can be the sensory loss in the palm, or maybe it is not there. The sensory loss at the 3.5 fingers will be there, but at the palm it may be there, it may not be there. So I will write plus minus sensory loss. But definitely the benediction deformity is not there. So due to this is not the answer. And similarly, when you talk about the carpal tunnel syndrome, in this the deformities are not seen, and there is only tingling sensation in the distribution of the median nerve. So that is why definitely this is also not the answer. And now we reach to the conclusion that the answer of this question is A. The answer of this question is A. Now over here we have discussed the median nerve, and if I say any other nerve question comes up, like for example if I say the ulnar nerve question comes up, so first of all you should be knowing sensory supply area, okay, which you already have understood in this image. Then secondly, you should be knowing it runs behind medial epicondyle. Okay, you should be knowing it is behind medial epicondyle. So that means if they mention medial epicondyle, fracture of the medial epicondyle, answer is ulnar nerve. Thirdly, partial claw hand. And when you say partial claw hand, which fingers? Medial 2 fingers. Okay, medial 2 fingers. So I will just quickly write medial 2 fingers. Okay, in the bracket I'm writing this. These are the 3 main points for ulnar nerve. And if you know these 3 points perfectly, you will be able to answer the question. Similarly, if I say for radial nerve, let us see about the radial nerve also. Now what are the key points for radial nerve? One key point is it is running in the spiral groove, or you can say related to shaft of humerus. So anything which is they are asking about this fracture at this shaft or at the spiral groove, you know they are talking about the radial nerve. Sensory, yes, sensory supply also we already know. And thirdly, wrist drop. So when you say radial nerve, these are the 3 main points which you should be knowing that it is related to radial nerve. Wrist drop means what? Loss of extension at wrist, loss of extension at the finger. So that is why it is in this way. Okay, so now we have quickly very good, Dr. Sam. So we have quickly discussed about these 2 nerves also, and we should be now able to differentiate the 3 nerves, because this is very important. Usually what happens, the confusion occurs between the nerves. So if you remember in this way that these are the main points, then definitely you will be able to solve the question. Now there's one more question. Yes, very correct, Hrithik. Whenever we are talking about the radial nerve, usually we are having the wrist drop. But if I talk about the posterior introitious nerve injury, that is a specific thing in which wrist drop is not seen or it is very weak, but the finger drop is present. Very, very correct. Now, let us see this question. Now, I will just give you a hint. It is also related to median nerve, but the question format is slightly different. Now, what is the question? The patient is complaining that he is having difficulty in closing the button. Like when you are closing the button of your shirt, you are doing this kind of movement. Plus, he is not able to make O like this. He is not able to make O with the fingers, and it is observed that yes, OK sign is abnormal. Now, this is the keyword over here. OK sign is abnormal. And now when you say OK sign, now quickly for the OK sign, we say it is actually anterior introitious nerve injury. The OK sign is basically for anterior introitious nerve injury. Yes, I can see you are answering. Yes, Ankush, very correct. You have answered AIN. And B, then you are saying C. Okay, right. There is a confusion between A. Okay, there's a confusion between B and C. Ritik B, Ankush, AIN, very correct. Now, when you say opponents, okay, opponents is what? This kind of movement. Opponents is doing this role. And over here, like when you are talking about OK sign means this. When you are doing, जब आप कहते हैं ना, wow, बहुत बढ़िया लग रहे हो, बहुत ही बढ़िया. तो it is like this. This is given the term as OK sign when you make the O like this. And when you're making O like this, not only the opponents, there are other movements which are occurring at the fingers, and let us see over here. So before we discuss anterior introitious nerve, it is specifically supplying what? It is supplying deep group, lateral half of flexor digitorum profundus, the flexor pollicis longus and pronator quadratus. Okay, this is the muscle supplied by it. And now what is this? This is the OK sign. And when you talk about the OK sign, this is the normal and this is the abnormal. So when you see, when you're making O or when you say OK to someone, so over here, not only the opposition movement, that is just a part of the movement, but you can see the flexion is actually occurring at the fingers. The thumb, when you are opposing it with this index finger, a flexion occurs. The flexion occurs at this thumb as well as the flexion occurs at this index finger, both the PIP and DIP joints of the index finger. So let us see, let us try to understand this in this normal person. What is happening at the thumb? The flexion is occurring. Okay, flexion is occurring at thumb. And now when we are talking about the flexion at the thumb, over here the muscle which is responsible is flexor pollicis longus for this flexion. Fine. Now let us see this movement also over here. Flexion. This is which joint? PIP, proximal interphalangeal joint. Again there is flexion at DIP, which is the distal interphalangeal joint. Crick fans, okay, thank you for asking. Yes, my health is fine now. Yeah, I was actually ill for last 15-20 days, quite ill. Thank you for asking. So over here what is happening? This is actually the complete OK sign with the flexion at both the joints of this index finger also. So this is the movement which is occurring in the OK sign. And now when you are saying flexion at PIP and DIP, what you are checking is the flexion at PIP is brought about by flexor digitorum superficialis plus flexor digitorum profundus. But when you talk about DIP, it is only the flexor digitorum profundus which is bringing about the flexion over here. Fine. Now, what is abnormal OK sign? Now, in the anterior introitious nerve injury, you know that which muscles are affected, and now which muscles are affected, I will just quickly highlight those muscles. The muscle affected is FPL. Okay, this is affected FDP. So you can see these muscles will be affected. FPL, FDP, over here also FDP. So now what happens? This movement only by these muscles, so they are majorly affected. But when you see this movement, flexion and PIP, if the FDP is affected, but still FDS is present, है ना? FDS आपका काम कर रहा है अभी भी. So because the FDS is still working, so the flexion at PIP is possible. So let us see at abnormal OK sign. This is abnormal OK sign. And now what happens? The joint at thumb, the flexion is, the patient is not able to flex at the thumb. And now when I see this one, this is PIP and this joint is DIP. So the flexion is DIP, it is not there, and PIP, the flexion is present. So now when such kind of situation is there, so we say specifically it is the injury of anterior interosseous nerve which is affecting the deep group of muscle, and the patient is not able to do this proper OK sign, or we are not able to make O, and this changes in this form as if you are doing like this up. You can say when you're pinching something, so you can see the difference over here. This is the difference over here, and this is what yes, this is the anterior interosseous nerve injury. So now let us see the muscles over here. When you see the muscles, of course the FDS is not affected. Apponens pollicis brevis, no, it is not supplied by anterior interosseous nerve. Adductor pollicis also, and the muscle which is over here, which is in accordance to the anterior interosseous nerve injury and the OK sign, is flexor pollicis longus. So the answer is C. Now quickly coming to the next question. I feel this is a question which you can do very well. It is a bit easier question, and this is a cross section at the level of the wrist. Thank you, Arpit. And similarly, I will suggest everybody of you, like you are saying, ma'am, please take care of your health, and I'm also concerned about your health, like all of you over there, because this is the time when you should take care of your health, and because you cannot waste even one day. So you have to take care of your health, because if you are at good health, you can study well. Your mind, your body will be sound to study, and because you have to give the average of around 10 to 12 or till 14 hours. तो आपकी body सही होनी चाहिए, आप health सही होनी चाहिए. Especially winters है, so you should prevent yourself from cold and this cold, cough, viral. Okay. Yes. I can see everybody answering over here. See, I will just give you the hint. What is true? Okay, you have to tell what is true regarding the arrow mark structure. When you see this arrow mark structure, what is this? This star is on flexor retinaculum. Okay, the star is on flexor retinaculum. This structure is actually flexor retinaculum, and this structure which is labeled over here, this is what? This is a nerve. Which nerve? Median nerve. Very correct. It is median nerve. So there is basically a confusion between A and D. Many of the students are answering D also. Read the D option again. Now you will understand why it is not D. Carefully read the. Yes, it is median nerve. So we have to tell that which statement is correct. Now, when you say it supplies the skin of lateral aspect of arm, we know very well, yes, it supplies the lateral aspect of arm. Posterior interosseous nerve is its branch. No, not the posterior interosseous nerve. It is anterior interosseous nerve, which is a branch of median. It supplies brachioradialis. No, brachioradialis is supplied by radial nerve. And now D option, its compression leads to cubital tunnel syndrome. Not cubital, this is carpal tunnel. A very small word which is changed over here, carpal, cubital. Usually what happens now? Usually what happens when we are in hurry, that we know the answer and we think that yes, this is an easy question and we know the answer. So we are in hurry. तो हम cubital को carpal पढ़ लेते हैं और हमें लगता है भी tunnel syndrome लिखा है तो carpal ही होगा. But this is the cubital tunnel syndrome, which is actually cubital tunnel syndrome is due to the compression of ulnar nerve, not the median nerve. So over here, when you are seeing this image, not only the median nerve, when we say what are the other structures passing deep to flexor retinaculum, it is the flexor digitorum superficialis, it is the flexor digitorum profundus, and it is the flexor pollicis longus. When this image is given, you should be able to identify other structures also, like for example over here, this is what? This is the carpal bone. Okay, this is the carpal bone. All these are carpal bones over here. Then apart from this, if I say these upper four tendons, this is the upper four tendons of flexor digitorum superficialis. Just below that, below four tendons is flexor digitorum profundus, and there is one more tendon over here which is towards the lateral side, which is the flexor pollicis longus. So in this image you should be able to identify the other structures also, because the question can be on median nerve or the question can be on the other structures also. They can ask you for the identification of other structures also. So over here the conclusion is, the answer is what? A. देखा वही हुआ ना, क्यूबैटल को मैम कार्पल समझ लिया था. एक्चुअली यही होता है बहुत जल्दी में जब हम आंसर करते हैं. सो समटाइम्स जो आपका दिमाग चाहता है वही आप पढ़ लेते हो. आपका दिमाग सोच रहा था मीडियन नर्व है तो कार्पल टनल होगा, बट इट इज एक्चुअली क्यूबैटल टनल. ओके, आई एम गिविंग यू वन एक्स्ट्रा क्वेश्चन बिकॉज वी हैव डिस्कस्ड इन डिटेल सो मच मीडियन नर्व एंड we have made it sure that we answer every question of median nerve in either of the way it is asked. ऐसे पूछे या वैसे पूछे, हमने आंसर करेक्टली करना है. तो एक और क्वेश्चन है, बड़ा इजी क्वेश्चन है. ऑलरेडी इट इज रिटन ओवर हियर. नाउ इट इज कार्पल. ओके, दिस इज द कार्पल टनल syndrome. All symptoms are seen. Please see it carefully. What is written over here? Over here I have written in capital except, but in the question paper it may not be written in capital. So whenever you're reading the last line of the question, you have to read the last line of the question carefully. They can say which of the statement is true, or they can say which of the statement is not true, which statement is not correct. All statements are true except. So the last line of the question, don't hurry so much. You have to read it carefully, last line, that what they are actually asking, because there are so many things you already know. There are so many things which you already know, but you cannot make silly mistake in these scorer questions. So yes, A, B, see over here for the carpal tunnel, we very well know that thenar atrophy is there because median nerve, it is a compression of the median nerve. Yes, A, C, B, A. Now the compression of the median nerve is there, so we very well know thenar atrophy is there because it is majorly supplying the thenar muscles. And now again I will just quickly come to this image and this will clear your answer. Where is this image? Yes, this one. If you remember, we have just discussed this branch is given before flexor retinaculum, which is supplying the palm area, and this branch is given after flexor retinaculum, which is supplying only the fingers. So what do you understand? palm की जो सप्लाई है, अगर हम मीडियन नर्व की बात करें तो वो पूरा लेटरल 3.5 सप्लाई कर रहा है, बट उसमें भी हमने कहा कि जो पाम की सप्लाई है वो फ्लेक्सर रेटिनिकुलम से पहले हो जाती है और जो फिंगर्स की सप्लाई है वो फ्लेक्सर रेटिनिकुलम के बाद होती है. सो व्हाट एक्चुअली हैपेंस इज, इफ आई से दैट कंप्रेशन इज ओवर हियर, that is the carpal tunnel syndrome. So this nerve is spared because this branch is before the flexor retinaculum. So the supply to the palm, lateral aspect of the palm is spared. But for the carpal tunnel syndrome specifically, we say sensory tingling sensation, the symptoms are specifically seen where lateral 3.5 fingers. So this is the catch over here in this question. So in this question, this is the catch over here. And yes, coming back to this question, so tingling is at lateral 3.5 fingers, but it is not at the palm. Over here we say this area is spared. And when you say paresthesia, tingling and the sensory symptoms increase in night time. So it is usually seen that the symptoms increase in the night time. So this is also correct. So the answer finally is C. Yes, C. The answer is C. Coming to the next question. And when you see this image, I know you very well know, I will write it, claw hand. Okay, everybody of you knows claw hand, but you should be able to correctly define it also. Because like why I have included this question now, because what happens now, whenever they are giving clinical question, they use such kind of statements. And when such kind of statements are used, you get confused कि अरे ये हो क्या रहा है, कहाँ पे कहीं flexion हो रहा है, कहीं पे extension हो रहा है, DIP पे कुछ है, PIP पे कुछ है. Now whenever you are answering the question, do the movement at your own hand. Like if the question is saying flexion at MCP, do the flexion at MCP. It is saying flexion at PIP, do the flexion at PIP. Extension at DIP, do the flexion at over there. So do it yourself and then you will be able to understand that what they are actually asking or what is happening over there. Yes, yes, Ankit, when you say carpal tunnel syndrome, the tingling sensation not at the lateral aspect of palm, it is actually the lateral 3.5 fingers. Over there, mainly over there the symptoms are there. Yes, yes, very correct. Everybody of you is answering. Yes, very correct. The answer over here is C. So you have very correctly understood. Whenever you are talking about the claw hand, we say this joint is what? It is the MCP joint, the metacarpophalangeal joint. And over here we actually say hyper extension is there, right? Hyper extension is there. Then another joint is this one, PIP, and this one is DIP. And at both PIP and DIP, we say flexion is present. So this is what is there in the claw hand. And now let us see the options over here. And when we see the option, so we definitely know that this is not the answer because it is written flexion at MCP. We have to actually decide between the three. So extension at MCP, but not the extension at PIP. Similarly over here, extension at MCP, flexion PIP, but not extension at DIP. So now the best answer over here is which one? The best answer is this. This is the best answer and therefore this is the answer. Though it is not written hyperextension, but when you see all, you know that this is the one, this is the statement which is actually totally correct. Yes. Yes, it is seen in, very correct, it is seen in the clump case palsy. So the key to success is to focus on the goal and not on the obstacles. And that is very true. Obstacles at this period of time is the distractions around you or the negative vibes around you. So don't focus on the distractions. Don't focus on any negative vibes or like if somebody is saying कि अरे तूने इतना ही पढ़ा है, ये भी पढ़ना था, वो भी पढ़ना था, अब कुछ नया पढ़ने का टाइम नहीं है. अब वो पढ़ो जो आप ऑलरेडी इतने महीने पढ़ चुके हो. मतलब आपको सिर्फ रिवाइज करना है, सिर्फ रिवीजन पे ध्यान देना है. नए कंटेंट की तरफ नहीं भागना है कि भाई ये तो मैंने पढ़ लिया, ये भी पढ़ लूँ, वो भी पढ़ लूँ. नहीं, पहले आप ensure करो, ensure yourself that whatever you have studied, do you know it or not? And if you think that the workbooks you are reading, still you need more revision, then focus on that only. Don't go here and there. And there are other distractions also. कोई कुछ बोल रहा है, कोई ये चीज़ बोल रहा है, कोई वो चीज़ बोल रहा है, कोई कह रहा है कि अरे हो नहीं पाएगा, कोई कह रहा है कि पता नहीं क्या होगा. Negative vibes, keep the negative vibes away. Focus your mind only on your studies and don't focus on any distractions or any negative vibes. Okay, now let us quickly come to this question over here. Negative vibes बहुत है. Yeah, I know that. ये जो टाइम पीरियड है, ये टाइम पीरियड ऐसा होता है कि नेगेटिव वाइब्स अगर थोड़ी सी भी होती हैं तो वो बहुत जल्दी आपके दिमाग को अफेक्ट करती हैं. और वही चीज़ है कि उससे आपको थोड़ा सा डिस्ट्रैक्ट होके, मतलब थोड़ा सा डिस्ट्रैक्ट नहीं, थोड़ा सा दूर होके चलना है. थोड़ा सा अपने आप को आइसोलेट करो. बस अपना दिमाग अपने शेड्यूल पे रखो, अपना दिमाग अपने फोकस पे रखो कि भाई मुझे ये पढ़ना है, ये वाला कंपोनेंट मुझे आज कंप्लीट करना है. एंड आई कैन डू इट एंड आई विल डू इट. Okay, now let us, yes, Kumar has started answering the question. B, D, common perennial nerve. See, when you are reading this question, you you know the answer of this question, but this is a question with the tricky language. You have to read the language over here. It may look like that the question may look like as if the question is on the nerve injury, but the question is not on the nerve injury. The question is on muscle supply. C, tibial nerve. B, very good, obturator nerve. Yes, yes. Aditya, Vikas, Shamlal, Nabil, Mohammed, Ritik, Deepshika, very, very correct, very, very correct. Now you have understood now what is actually happening. Sciatic nerve involvement is there, which is a nerve for the posterior compartment of the thigh, supplying the hamstring muscle. So that is why they are affected. But now the next statement is what? What is the next statement? Yes, B. Very correct, Dr. MS. B for sure. Now, what is there? It is seen that one of the muscle is paired. One of the muscle is paired. Why? Because it is a hybrid muscle. So, actually, the question is on the hybrid muscle. And hybrid muscle is what? Hybrid muscle is the muscles with dual nerve supply. Means one muscle which is having supply by two nerves. and due to this muscle is spared. So the muscle is spared due to supply by which another nerve. So what do we mean कि एक muscle ऐसी है जो sciatic nerve से भी supplied है और किसी और nerve से भी supplied है. तो अगर sciatic nerve injure हो भी गई तो भी उसकी supply आ रही है. क्यों आ रही है, कहाँ से आ रही है, ये हमें बताना है कि उस मसल की सप्लाई एक्चुअली में आ कहाँ से रही है. सो द क्वेश्चन इज ऑन द हाइब्रिड मसल एंड okay, so for the posterior compartment of thigh, we say these are the muscles. The nerve is sciatic nerve, muscle is hamstring, shorter of biceps femoris. In the hamstring, all these are the muscles and all are supplied by sciatic nerve. But if you see over here, this one muscle is what? Adductor magnus. Some fibers of adductor magnus, which is termed as ischial head, it comes over here and becomes a component of hamstring. But you know, adductor muscle is a muscle of what? It is a muscle of actually medial compartment. So this adductor magnus is supplied by sciatic nerve, plus because it is a muscle of medial compartment is also supplied by obturator nerve. So the nerve for the medial compartment of thigh is obturator nerve. So when you say adductor magnus, so it is supplied by this obturator nerve plus some fibers supplied by sciatic nerve. Okay, so in the lower limb, one muscle is this adductor magnus. I will mention more muscle. One more is there, pectineus. When you talk about the pectineus muscle, it is actually supplied by again two nerves, femoral nerve plus obturator. And there is one more muscle which is biceps femoris. Okay, biceps femoris is actually supplied by what? It is supplied by tibial part. Okay, I'm writing tibial part and common peroneal part. See, I'm underlining the word part because this is the part of sciatic nerve. This is not individual nerve over here. This is a part of sciatic nerve, the tibial part of sciatic nerve and the common peroneal part of sciatic nerve. You should be able to understand part means component. But this is a component of sciatic nerve. This is not tibial nerve. This is not common peroneal nerve. So what I mean to say, when you talk about the biceps femoris, this part is supplied by common peroneal part of sciatic nerve. This part is supplied by tibial component. मतलब sciatic nerve के दो component है, दो parts हैं. एक कंपोनेंट किसी और मसल को सप्लाई कर रहा है, दूसरा किसी और को. बट एक्चुअल में हम अगर देखें तो ये दोनों कंपोनेंट्स ही किसके हैं? sciatic nerve के. So now both the components are of sciatic nerve and we already said sciatic nerve is affected. So if the sciatic nerve is affected, the whole of the muscle is gone. And only one muscle is spared, which is adductor magnus. And now we know why. Because it is supplied by obturator nerve. So the answer of this question is yes. The answer of this question is B. Okay, now just read this question and try to answer it. In speaking, like the patient is having difficulty in speaking, then then you are having gait ataxia. Ataxia means that the patient is not able to walk because the equilibrium of the patient is disturbed, right? Yes, very, very correct. I can see a lot of answers and a lot of A. Very correct. Saddam, Ayushi, Hani, med surgeon, Mir, Ayush, Nabil. Okay, very, very correct. And now what is actually happening over here? The MRI shows infarction where? Infarction, dorsolateral aspect of medulla. See, over here, this is a very, very good hint actually. It is a very good hint. And when you see this, you know medulla is affected. It will be a medullary syndrome. And the question itself is telling you lateral aspect of medulla is affected. So the answer will be what? Lateral medullary syndrome. तो अगर क्वेश्चन खुद ही कह रहा है कि मेडुला अफेक्टेड है तो मेडुलरी सिंड्रोम होगा और वो खुद ही बोल रहा है कि लेटरल एस्पेक्ट अफेक्टेड है तो आंसर क्या हो जाएगा? लेटरल मेडुलरी. Okay, this is just I'm telling you a easy way, like a easy trick to answer. If it says medial aspect of medulla is affected, you know the answer is what? Medial medullary syndrome. So let us quickly see over here. When you say lateral medullary syndrome, it is the Wallenberg syndrome. Yes, A for sure, Dr. Beyond, very, very correct. Yes, very correct, Paika. So over here, what is happening? This is the section of the medulla. And if you see this, over here, the lateral, which is slightly on the posterior side, dorsolateral aspect over here is the portion of the medulla which is affected. And because this lateral aspect is affected, so that is why it is given the term actually lateral medullary syndrome due to the occlusion of posterior inferior cerebellar artery, Pica. And there are multiple symptoms over here like nausea, vomiting, ataxia, vertigo, difficulty in speech, swallowing, the taste sensation is also gone, and a very important symptom, contralateral loss of pain and temperature. So you can say multiple symptoms along with this symptom. It is what? Lateral medullary. And when you say medial medullary, this area is affected. So what is this area? Of course, this is the medial area of the medulla. Okay, this is a section of medulla. Medial aspect is affected. So medial medullary syndrome due to anterior spinal artery occlusion. And over here, the key word is yes. Yes, very correct. So over here we say cranial nerve 12 is affected, which is a keyword for medial medullary syndrome. And along with that, the two other symptoms are contralateral hemiplegia and the contralateral loss of this vibration and the conscious proprioception. Now the other points are Brown-Sequard syndrome. Now when you say Brown-Sequard syndrome, what is there is, it is actually hemisection of what? Spinal cord. Over here the spinal cord is affected. Okay, over here spinal cord is affected, and there are three symptoms over here. What are the three symptoms? First is ipsilateral hemiplegia, ipsilateral loss of conscious proprioception and vibration, and contralateral loss of pain and temperature. Okay, so these are the three specific symptoms of Brown-Sequard. And now when you say Weber syndrome is, it is a lesion at the level of midbrain. Okay, it is a lesion at the level of midbrain. So earlier two lesions, medullary, were in the medulla. Brown-Sequard syndrome, spinal cord. Weber syndrome, midbrain. And the key symptom over here is cranial nerve 3 involvement, same side ipsilateral with contralateral hemiplegia. So these are the four syndromes over here. And the answer over here we have very, very well understood is the lateral medullary or Wallenberg syndrome. Okay, now let us come to this next question, and this is a topic which we cannot leave. We have to discuss this topic because the pulsation question is coming in every exam, and for a long duration of time, like for 3 years, they are continuously asking the question on pulsation. You know that they are usually asking the posterior tibial artery pulsation, but they can ask any of the pulsation. Like this year in the January, they have asked you common carotid artery pulsation. So either it is repeated or some new pulsation can be asked, like over here. Yes, very correct. Very correct over here. Over here, when you are feeling the pulsation over here, you know very well that this is which artery present over here. This is radial artery. Okay, this is a radial artery pulsation, and we are doing the pulsation over here. We are palpating the artery over here. Now, what is the location for pulsation? Now, when you see this hand over here, where are you keeping the fingers? Which side? Lateral side or medial side? So, when you do the pulsation yourself, ठीक है, खुद pulsation जब आप करके देखोगे, आपको पता है कि आप कहाँ पे finger रख रहे हो, lateral side की तरफ. So now we know the word lateral. It will be lateral. Now lateral to what? Lateral to the tendon which is present on the lateral side. So lateral side tendon is which one? Radialis or ulnaris? Yes, radialis, lateral side. Ulnaris is on medial side. So we very well know that ulnaris is not the answer. It is the radialis. And in the radialis also, where? Yes, lateral to flexor carpi radialis. मतलब lateral side पे तो pulsation ले ही रहे हो, और कौन से tendon से related? जो tendon यहाँ lateral side पे है, flexor carpi radialis. Very correct all of you. It is, answer is C. And let us quickly go through this radial artery pulsation, lateral to flexor carpi radialis. Over here at the cubital fossa, it is the pulsation of brachial artery, specific location medial to biceps brachii tendon. And when you see over here, the most commonly asked pulsation, posterior tibial artery pulsation, where between medial malleolus and tendocalcaneus. And one more pulsation over here on the dorsum of the foot is dorsalis pedis artery, which is what? Lateral to extensor hallucis longus tendon. Okay, these are the most important pulsations which you should be knowing very well. Yes, this pulsation is over here, common carotid artery pulsation at which vertebra? C6, which tubercle? Carotid or Casernaic tubercle. So these are the most important pulsations of the body which you should be perfectly knowing. So over here the answer is what? Answer is C. Yes, answer is C. Now, yes dear, in this year, in January common carotid artery was asked, and in this July exam the posterior tibial artery was asked. So definitely keep working hard. You can get anything that you want. See, at this moment of time, there is only one option for us, and that is to study. There is no other option actually. ना आप पेपर जाके बना सकते हो, ना आप पेपर को चेंज कर सकते हो, ना ही आप पेपर अपने अकॉर्डिंगली याद कर सकते हो. The thing is that you have to study. And you never know when you get lucky. Maybe in the last 15 days, whatever you are studying, there are chances that question can come from that only. So you may be lucky also. Sometimes what happens, we think that we are not able to study well, and sometimes a health issue is there, or due to some personal family reasons, we are not able to study for a duration of the time, and we feel like that we have lost those 1 week, or we have lost those 3-4 days. How will we manage? So see, never lose hope. Just keep studying. You never know that suddenly the God makes you lucky on that day, that whatever you are studying, the question comes from that only. तो आप कहते हो ना कि भी हम को समझ नहीं आ रहा है कि हम तो जो पढ़ते हैं वो आता नहीं. अरे जो पढ़ते हो अगर वहीं से आ गया, आता तो है ही क्वेश्चन. कई बार आता है क्वेश्चन, जो आप पढ़ते हो एग्जैक्टली वैसे क्वेश्चन आ जाते हैं. सो देयर मे बी अ चांस दैट whatever you are studying, the question comes from there only. So never stop. You never know कि God when the God will make you lucky. और कहते हैं ना कि कब जब सक्सेस आता है तो छप्पर फाड़ के आता है, तो कभी नहीं पता आपको कि कब दिन बदल जाए. तो आप वेट मत करो किसी चीज़ की, होप मत लूज करो. कभी नहीं पता कब वो दिन आ जाए, और अचानक से आएगा. सब कुछ एकदम अचानक से होगा, बट उसके लिए ना आपको एक कंटिन्यूअस एफर्ट्स देने हैं. Yes, very, very correct. The answer of this question is A. Yes, very, very correct. See, I have included this question because again, this question is a very important question from which always there is some question. And the question can be anything. Like they can ask you about the structures derived from it. They can ask you regarding the nerve, that which is a nerve or which arch, or the artery. They can ask you either of the question. Like over here we have included, like if you see, this is the arrow on what? It is the arrow on the first arch. Okay, and when we talk about the first arch, we say all these are the derivatives from the first arch. These are the structures, very, very important: malleus, mandible, muscles of mastication. Nerve of first arch is mandibular, artery is maxillary, sphenomandibular incus. Like all these, all the structures are from first arch. And if you see dominant alphabet, M is there. All the structures which are derived from M, like which are starting from M, they are from first arch. So let us see, yes, all the structures from first arch. Mandibular nerve is from the first arch. If you see, we have written over here malleus as well as incus from first arch. And now when you talk about stapes, it is actually from second arch. It is actually from second arch. So now let us go back to the question. What is correct about the statement? Very, very correct. Yes. What is correct about this question? Yes, mandibular nerve is the nerve of this arch. Very correct. Ductus arteriosus is derived from it. No, it is not derived from first arch. It is actually derived from sixth arch, and that too from the left side. Stylet process from this. No, it is from second arch. Ear ossicles, all ear ossicles from first arch? No. Only the malleus and incus from first arch. Stapes from second arch. So now we know the answer of this question. And yes, whenever you are doing the arches, make it sure that you know the nerves of all the arches in which these two are more important. First arch, M, again the M alphabet, mandibular nerve. And the second arch, facial nerve. These two very, very important. And the arteries, all the arteries are important over here. First is what? Again M, maxillary artery. Second arch, mainly stapes is developing, okay, from second arch now, so stapedial artery. Third arch, carotid arteries. Fourth arch and the sixth arch, like they are giving rise to all these structures, but most important, fourth arch, arch of aorta on left side. This is very, very important. And the sixth arch, ductus arteriosus on left side. So I am highlighting this also because these are two which are the most important. And you know that ductus arteriosus was recently asked in this recent exam July, which came up as a new question. And when we are talking about the ductus arteriosus, in this image I have shown it separately over here. This is it is the ductus arteriosus. This is a location, and now we have understood this is derived from left sixth arch, or sometimes they use the word aortic arch or aortic artery. And another important point is a nerve is there which winds around it, and the nerve is left recurrent laryngeal nerve which winds around it. So these are the 2 points which you surely should be knowing about the ductus arteriosus. So in this one question, we have discussed a lot of points, and finally the answer over here is A. Let us quickly come to the next question. Okay, so now let us see the next question over here. The arrow is over here. So a patient has lost. Yes, very correct. Rishikesh, very sure. He is very sure answering C. Manohar, Naresh, Rashik, Kitab, Shivani, Ashish, yes, very correct. Yes, over here see what is there is the loss of taste sensation from the arrow marked part of the tongue. And when you see this arrow marked part of the tongue, which part is this? Anterior or posterior? You know this is the anterior part. The tongue is divided into anterior 2/3, posterior 1/3 and the posterior most part. So of course the arrow is on anterior part, means they are talking about anterior 2/3 part of the tongue. And over there the taste sensation is lost. Along with that, decreased secretions from submandibular gland. And now the nerve which is damaged is a branch of cranial nerve 7, which we know is the facial nerve. All the points are favoring towards what? Yes, very, very correct. All the points are favoring towards the chorda tympani nerve. Why? Because first of all, anterior 2/3 of tongue taste sensation carried by chorda tympani. Secondly, submandibular gland secretion also supplied by chorda tympani nerve via submandibular ganglia. So if you remember parasympathetic ganglia over there, COPS. So we said submandibular ganglia supplies submandibular gland. Secondly, facial nerve branch, that also we already know it is a branch of the facial nerve. And in the anterior 2/3 we say a very, very important point is, one is taste sensation, chorda tympani. Another very important point is general sensation by which nerve? Lingual nerve. So this anterior 2/3 part is most important. And over here I will also mention lingual nerve is related to third molar tooth. Now this relation is very important because sometimes it is mentioned in the question or it can be asked as a separate question. And also it is related to what? Submandibular. See, I have written over here duct, not the gland. It is related to submandibular duct. So this is a very important relation of the lingual nerve, and sometimes they ask you in the question or they can ask you separately also. So this whole component is very, very important. And now definitely you know the answer of this question is chorda tympani nerve. Still this question on this nerve has not been asked till now. So there can be a question like lingual nerve question has already come, but the chorda tympani nerve question has not come till now. Okay, now let us go to the next question over here. Yes, very correct, Aditya. Sobia Ansari, very correct. Yeah, med world. So now let us see a patient. See over here. Now again, this nerve injury question is there. Any of the nerve injury can be there, but you should be able to differentiate that if this nerve injury is there, what symptom will be there. तो basically आपको symptoms के basis पे differentiate करना है. And now in this lower limb nerve injuries also, if you know the area of the sensory loss, again it will help you to answer the question. Like over here, I'm just marking sensory loss where dorsum of the foot. Even if you are not able to understand the question, आपको नहीं समझ में आ रहा, eversion हो गया, eversion चला गया, dorsiflexion नहीं गया, मतलब हो क्या रहा है, तो आप क्या देखो, sensory loss. See the sensory loss and it will quickly lead to you to the answer. And if I say dorsum of the foot, like majority of the dorsum of foot is affected, so that is actually supplied by what? And I can see a lot of you are answering this question. A, okay, you have answered B also. Then again a lot of you have answered A. Rohit, Ansar, Khurshid. Yes. Now, when you see this typical symptom along with loss of eversion, the rest of the movements are normal. So, which nerve is involved? Yes, in this case is superficial peroneal nerve. And see, whenever you are doing the question over here, question can be on this, on deep peroneal nerve, or the question can be specifically on the tibial nerve also. So basically, you should be able to differentiate that how you have to answer the question, and for this, you should be knowing this flow chart. If you know this flow chart, you can easily answer the question. Sciatic nerve divides into tibial and common peroneal. Tibial is a nerve for posterior compartment. Common peroneal winds around neck of fibula and divides into deep and superficial. Deep is the nerve for anterior compartment of leg, and the superficial is a nerve for lateral compartment of the leg. Okay, so anterior side deep peroneal, posterior side tibial, lateral side superficial peroneal. Now in this I will add one more thing. For anterior compartment, the action which is there for anterior compartment is dorsiflexion, the common action for anterior compartment. The common action for the posterior compartment is plantar flexion, and the common action for lateral compartment is eversion. Okay, I've added over here so that you will understand that if the anterior compartment, this nerve is gone, there will be loss of dorsiflexion. If the posterior compartment is gone, tibial nerve, loss of plantar flexion. And if superficial peroneal nerve is gone, there will be loss of eversion. So now you know dorsi and the plantar. Dorsiflexion is what? When the foot is going like this, or it is you're pulling the foot towards the leg, that is dorsi, and the opposite is plantar. A very easy way to remember is when you're doing dorsiflexion, you are pulling your foot where? Towards the anterior side. So this is the action of anterior side muscles. And if you're doing opposite movement, you're taking the foot slightly backwards, so that is action of posterior side. ठीक है, dorsiflexion में आप foot को आगे की तरफ खींच रहे हो, तो ये anterior side की muscles का action हो गया. Opposite हो गया posterior side का movement, plantar flexion, posterior side की muscles. और जब आप अपने foot को lateral side पे pull कर रहे हो, lateral side पे pull कर रहे हो means soles out, and this is eversion. So now one component is this, another component is sensory supply. Now in the sensory supply, deep peroneal is only supplying this area which is the skin of the first web space, and the majority of the area of the dorsum of foot is supplied by superficial peroneal nerve, as well as it is going towards the lateral aspect of leg also. So if I say the question is saying dorsum of the foot, this is the dorsum of foot, so the nerve affected is superficial peroneal nerve. And if they specifically say skin of the first web space, then we say the answer will be deep peroneal. And when we say what about the tibial, it is supplying the skin of sole, it is supplied by tibial nerve. So when the tibial nerve is affected, the sensory supply lost where? Skin of the sole. Fine. So now we have understood that how we have to approach the question. First of all, you should be knowing this flow chart. If you know this flow chart, you can answer all the questions over here. And common action I have mentioned. We have mentioned the sensory supply also over here. So let us just try to see over here. If I say sciatic nerve gone means everything is gone. Whole leg is gone, right? If I say common peroneal nerve injury is there, then these two compartments are affected, right? And if we say individual compartments, then individual movements are affected. So now let us quickly see how we are going to approach the question. First is, if we say common peroneal nerve is affected, means two compartments are affected, loss of dorsiflexion and loss of eversion, which is what it is, foot drop. And over here, this is actually, when you are talking about the foot drop, for the foot drop, this is the first best answer, right? Along with what? Along with sensory loss at lateral aspect of leg plus dorsum of the foot. The whole dorsum of the foot is gone. So this is a foot drop, but now when you compare it with deep peroneal nerve, only one action is affected, loss of dorsiflexion. That also leads to foot drop. Sensory loss only at the first web space. Only these two things are present, right? Foot drop, first best answer, common peroneal. Now what will happen if the superficial peroneal is gone? Loss of eversion, sensory loss over dorsum of the foot and as well as the lateral aspect of leg. But when the tibial nerve is affected, sensory loss on sole of the foot and plantar flexion is gone. So same thing which we have understood in the flowchart, I have just written over here so that you are able to differentiate that how to approach for different nerves, and finally we reach to this conclusion that answer is what? Superficial peroneal nerve. Okay, so now over here this was a question which is very important. Why? Because by this question you now understand that how to approach the nerve injuries towards the leg area, because usually there is a confusion between common peroneal, superficial peroneal, deep peroneal. So you should be able to differentiate it. Okay, so now let us come to the next question over here. Yes, very correct, MR Khan. Yes, MR Khan, foot drop. The best answer is common peroneal, also seen in deep peroneal. Yes, MR Khan, you have correctly understood. Ajay, okay, you have started answering the question. Okay, I think the image is not visible. Now it is visible. See, now in this question, what is there? This is the anterior aspect of brainstem. First of all, you should be able to identify the cranial nerves. Secondly, over here we have also discussed the nerve injuries. So you should be knowing that if that specific nerve is injured, what is the main symptom which will occur? So first of all, yes, I can see a lot of yes, very correct, very correct. LR6, Keith, very correct. B, a lot of you are answering B, then C also, D also. Oh, thank you, Ankit. D, Ankit, मैंने मैसेज पढ़ लिया था, थैंक यू भी बोल दिया मैंने. B, Stuti saying B and Rajesh saying D. Okay, now let us see how to approach to this question. Okay, very, very correct. The point is, which of the following is correct? Now, let us first of all identify the nerves. Now, whenever you are seeing this nerve, I will first of all write the nerve. This is cranial nerve. Okay, this is the cranial nerve 10. Then this is the cranial nerve 6. This is the cranial nerve 5. This is the cranial nerve 3. These are the cranial nerves. And now let us try to identify the cranial nerves. Now, when you see this cranial nerve, this is the third one. Fourth is actually not shown. Fourth is coming up like this. This cranial nerve is 4. Then 5, 6, 7. This is 8. This is 9. This one 10. This one 11. And one more cranial nerve is there, which is slightly on the anterior side over here. This is what? It is the 12th. So all these, yes, very correct, Stuti. Good, doctor. Alan, very correct. So yes, you have correctly understood, and when you see this image, you should be able to identify all the cranial nerves, and a very easy way to identify all the cranial nerves is counting should go from inner to outer side. 3, you can see over here, 3, 4, 5. Okay, again the counting is going from inner to the outer side. So I will just zoom it over here. Let us do the counting. 6, 7, 8, 9, 10, 11. So they are in order. only the 12th cranial nerve is slightly on the anterior side. So this is how you are identifying the cranial nerves over here. You should be able to correctly identify it. And let us see, if the cranial nerve 3rd is affected, oculomotor nerve is affected, a very important symptom is down and out position of the eyeball. Okay, this is the main symptom over here. So for the oculomotor nerve lesion, we say the main symptom is down and out position of the eyeball, because the lateral rectus and superior oblique, they are spared, because we know LR6SO4. Oculomotor nerve is supplying all the muscles except LR6SO4, so they are spared, due to which the position of eyeball goes out and down. This is the most important symptom of oculomotor nerve injury. And apart from this, one more symptom is fixed and dilated pupil. So these are the two main symptoms of oculomotor nerve lesion. Let us come to the fifth. Fifth is actually supplying the skin of face. It is giving sensory supply to the whole face except the angle of mandible, and the skin over the angle of mandible is supplied by greater auricular nerve. So it is actually supplying trigeminal skin of the face. Cranial nerve 6, lateral rectus, abducent nerve, you know LR6, it is supplying what? Lateral rectus. And if this nerve is injured, the lateral rectus will be paralyzed and the patient will have problem in seeing where? Towards the lateral side. The lateral rectus paralyzed हुई तो patient lateral side पे नहीं देख पा रहा. And when you say cranial nerve 10, it is the vagus nerve which is supplying different structures, but yes, it is not supplying the tongue. When you say the tongue area, for that we say cranial nerve 12, hypoglossal nerve, which supplies the tongue muscles. So now let us come back to the question over here. If I come back to the question, so we know that A is not supplying the muscles of tongue because it is not hypoglossal nerve. B, the injury to the B leads to difficulty of eyeball movement on lateral side. This is correct. C is not supplying the face, it is supplying the skin. Okay, it is supplying the skin. And when you say D1, difficulty in looking downwards, not looking downwards, it is down and out movement. So the three options, these are wrong, and the answer of this question is yes. The answer of the question is B. The answer of this question is B. Okay, so first of all, you should be able to identify the cranial nerve. Secondly, we have understood the nerve injury is also over here. And quickly, I will also talk about the cranial nerve 4 injury. If the cranial nerve 4 injury is there, then in this case, we say patient has difficulty in looking downwards. And why it is there, we know very well, because why the patient has difficulty in looking downwards, because it is SO4. The superior oblique is supplied by 4th cranial nerve, which leads to the depression of eyeball. So the patient faces difficulty in looking downwards. That is due to the cranial nerve 4 involvement. And whenever the cranial nerve 12, hypoglossal nerve, is injured, so we say tongue muscles affected and deviation of the tongue to the same side of the lesion. Okay, so over here we have understood these nerve lesions, and tell yourself you can and you will. So this I am saying from the starting of the session only, that you can, and just keep telling yourself that I can and I will do it. Nothing can stop me. And now coming to this question, which is actually again a very important question and a very frequently asked question. From past 3 years, the question is coming up from this abdominal planes. And now this question you cannot do wrong. This question should be a scorer. कोई भी 1% भी mistake नहीं करके आएगा, सब इसका correctly answer करके आएंगे. कोई सा भी plane पूछे, you should be able to answer. Now over here, very good medicos. So now, first of all, you should be able to identify the plane. Yes, A. Then you are saying D, Aditya A, Ayushi A, Manohar, Ayushi, Rishik, Ritik, Priya, everybody is saying A. Okay, so many of you are saying A, so we will go for A only. This is what? It is a subcostal plane. But, yeah, it is a subcostal plane, and if you see, subcostal plane is also written over here. So basically, you have to decide between these two options. Okay, we have to decide between these two options, and yes, all of you are correct. It is, answer is A. It is the upper border of L3. Okay, A, B, C. See, this is not transpyloric. This is a subcoastal. This is the red colored plane. This is a red colored plane which is above the umbilicus. You know that what is this? This is the umbilicus. So the plane which is above the umbilicus is subcoastal. Below the umbilicus is transtubercular. And then you should be able to tell. You should be able to tell the level also. If Shan Ashraf, that's great. Yeah, very good, Bhavnesh. Umbilicus is between L3 and L4. Like we basically say umbilicus is at the level of L4. Okay, and you can say yes, junction of L3 and L4 also. Now, when you're talking about the planes, when this image of the quadrant is given, you know that umbilicus is present at this level. The plane above the umbilicus subcoastal, below the umbilicus is transtubercular. The subcoastal plane is which level? L3, and this transtubercular, it is at the level. It is at the level of L5. Okay, so L3 and L5, for both of them, it is the upper border. Whenever these quadrant planes are asked, always the quadrant image is given. And if you see this image, now in this image, what is this? This is a plane passing through the highest point of iliac crest. And whenever this image is asked, okay, why not the option C you are saying? Because if you see, option C is saying L4. It is not L4, it is L3, upper border of L3. Okay, subcoastal is not L4, it is L3. So that is why it is not option C. So what I was saying is, when they are asking about the supracrystal plane, which is at L4 level, lower border, always they will give you this image showing the bony pelvis, plane passing through highest point of iliac crest. Another plane is transpyloric, and for the transpyloric plane, more chances that they will give you image like this, and this plane which we have marked over here is transpyloric plane. And what is this transpyloric plane? You can see it is a highermost plane because it is at the level of L1. So it is a plane which is above, and you can see this plane is so much above that it is far away from umbilicus. So if you see any plane which is higher up in the image or in the abdomen area, that is the transpyloric. And in the same image, if I mark subcoastal, this is the location of subcoastal plane, this is the location of transtubercular. ठीक है, इसमें above plane subcoastal है, below umbilicus this is transtubercular. So now you are able to differentiate that transpyloric plane is higher up. It is a higher up plane. Yes, very correct, MR Khan. And now see, in these planes, I have always received a lot of queries, ma'am, we are not able to memorize these planes, or we get confused in this. So if you can do some trick or some mnemonic for that. So I've just made this mnemonic yesterday only, and so that it can help you in answering this question. See, whenever we are answering the planes, what you see is the word transpyloric, transtubercular. Trans word is common. So of course we cannot make the mnemonic from trans or alphabet T. Similarly, the word subcoastal, supracrystal, SS alphabet is same. So we cannot make the mnemonic from S alphabet. ठीक है, S और T alphabet से तो आप mnemonic बना ही नहीं सकते. Now what is different over here? Word is coastal, tubercular, another word is pyloric, fourth word is crystal. So we are going to make the mnemonic from these four words, and there will be no confusion between these four words क्योंकि चारों words different है. All the four words are different. And now what is the mnemonic is, like we are going to buy something from the mall. Okay, what we are going to buy something, we are going to buy a very pure thing, and whenever you are going to buy any pure thing, you know it is very costly. है ना, कोई भी अगर आप प्योर चीज लेने जाते हो, जैसे आपने प्योर डायमंड लिया, प्योर पश्मीना शॉल लिया, या कोई भी प्योर चीज लेते हो, it is always very costly. So pure and costly, what? So we are going to buy crystal tub. बड़ा ही क्रिस्टल वाला चमकता हुआ टब खरीदने वाले हैं. So pure and costly. Pure है तो costly है. Crystal tub. We are going to buy pure and crystal tub. Where? At Lulu Mall. Now you will say, ma'am, what is this Lulu Mall? Lulu Mall is, it is a chain of malls, and this mall, the Kerala people, students, they must be knowing it very well, because this Lulu Mall is actually a big, it is in Trivandrum also, and in this Trivandrum, this Lulu Mall is actually the biggest mall of India and the second biggest in Asia. So Lulu Mall. So we are going to buy what? Pure costly crystal tub at Lulu Mall. And now what is this? When you say pure, pure means pyloric. When you say costly, costly means coastal. ठीक है? Transpyloric plane, subcoastal plane, crystal. जैसे हमने बोला crystal, you know crystal, supracrystal plane. जैसे आपने बोला tub, as you said tub, tubercular. It is a transtubercular plane. So we are using these words. Where are we buying it? We are buying it at Lulu Mall. And 1, 3, 4, 5. So over here 2 is not there. 1, 3, 4, 5. Now let us see what pyloric. L1. What is this L? L is actually lower border of L1. This is lumbar vertebrae. So we know that we are talking about the lumbar vertebrae. I'm not writing over here. L1 lower border. And now when you go to coastal, subcoastal plane, what is U? U is upper border of L3. When you say crystal, again L, lower border of L4. When you say tubercular, again what? U, upper border of the L5. So we will remember pure and costly crystal tub. We are going to buy from Lulu. Lulu means lower, upper, lower, upper. What vertebra? 1, 3, 4, 5. Okay, so if you are not able to memorize the yeah, the Lulu Mall is actually, a lot of branches have opened, and first time when I heard the name of this mall, I was like, such an interesting name. So yeah, so it is 1, 3, 4, 5. Okay, pure costly crystal tub. So if you are not able to memorize the planes, memorize this mnemonic. Pure और costly चीज खरीदो और planes को answer कर दो. Crystal tub खरीदो Lulu Mall से. So now over here, yes, this is subcoastal plane. Now let us come to the next question. Lucknow also. Yeah, it is in the Lucknow also. Now let us see this question. You know that till now the question has been asked on this landmark, which is lesser trochanter of the femur, and great. Yes, Ajay Sharma wo. Nabil, Govind, Medico, Dr. Beyond. Okay, Lulu means pearl. Actually, I had no idea about this. Thanks for telling, Nabil. This mall has come up from UAE. Actually, this mall was in UAE. The branches have opened over here. Yes, very correct. The answer is C. The answer is C. And see, till now the lesser trochanter, it has been asked as a question. If it is repeated, very good for us. But if it is not repeated, very high chances, greater trochanter. So for the lesser trochanter, muscle attached to it, iliacus, psoas major, which is also termed as iliopsoas, both are helping in the flexion. But when you say greater trochanter, the arrow is where? Arrow is on greater trochanter of the femur. And if I say arrow is over here, what muscle? Gluteus medius and minimus. Twins. जुड़वा भाई, medius और minimus साथ में, medius and minimus attached over here, both are helping in what? Abduction where? Hip joint. It is helping in the abduction at the hip joint. So if there is a fracture over here, these two muscles are paralyzed, and what action is lost? Yes, this action is lost. What action? Let us see now quickly over here all the options. Yes, loss of abduction. Where? At the hip joint. So the answer of this question is C. Very correct, all of you. Okay, A, football mania. Okay, medius minimus, very correct. And the medius minimus, very correct, MR. It is supplied by superior gluteal nerve. So very correct. This is the answer of this question. And if I say, what about this option? Loss of flexion at hip joint. This is due to the involvement of lesser trochanter. So we have understood the answer of this question. Answer is C. And let us quickly go to this question. Very correct, MR Khan. Superior gluteal nerve injury, Trendelenburg sign, lurching gait. Very correct, Injamul. Good, doctor. Yes, Aditya. Correct. Okay, now over here, let us see this question. Venous cut down is being done. What? For what? For excess of great saphenous vein. And now when this great saphenous vein, the procedure was done, the patient complained of some symptoms. Now which statement, what I'm saying, not correct, which statement is not correct regarding great saphenous? So basically, we are not talking about the nerve injury, we are not talking about the symptoms, but we are saying that we are talking about the great saphenous vein, that what is not correct about it. So you should be knowing the various points of great saphenous nerve, because currently this is a very, very important topic. And let us see, try to answer this question. So which statement is not correct over here? Yes, very correct. A lot of you are answering B. You're also answering A. One answer is from A also. So Ankit, Sheikh, Shraddha, Ambika. B. Yes, very, very correct. So over here, before we go for the options, we will quickly see over here, this is a great saphenous vein. And when you talk about the great saphenous vein, it is actually on medial aspect of thigh, and it is present in this whole extent. And there are two landmarks which are very important over here. One is this medial malleolus. You can see medial side, so it is related to medial malleolus. Over here, this landmark is medial malleolus, and if you see, the vein is running anterior to the medial malleolus, not posterior. So it is running anterior to the medial malleolus. How many centimeter? 2.5 centimeter. This is very important landmark over here. Another important landmark is towards the thigh region. The great saphenous vein, I will show in this color over here. It is going towards the deeper aspect because it drains into the femoral vein. Take a great saphenous vein, it drains into femoral vein, but the great saphenous is present in the superficial aspect, and when it is going to the deeper aspect, it has to pass through an opening. And now this opening is saphenous opening. So what happens? The great saphenous vein passes through the saphenous opening, and then it goes deeper to drain into the femoral vein. And the saphenous opening, it is around 4 centimeter below and lateral to pubic tubercle. So this is another landmark which you should be knowing very well. Now a very important point over here for the great saphenous vein, it is related to what? It is related to saphenous nerve. This is a very important clinical point. So two anatomical points very important. Third anatomical point related to saphenous nerve. So that is why if you are doing any procedure on the vein, there are high chances that you can injure the saphenous nerve. And if the saphenous nerve is injured, sensory loss is seen in this area. And you can see which area, mainly the medial aspect of leg. The sensory loss towards the medial aspect of leg, it can go till the medial border of the foot also. So if the saphenous nerve is injured, this is a clinical symptom. So we have understood complete, yes, we have understood we have understood the complete question. Let us come back to the question. Which statement is not correct? This is correct, 2.5 centimeter anterior. But yes, it is not posterior to the medial malleolus. Third point is correct. It is related to saphenous nerve. This point is correct. It is passing through saphenous opening. So all the points are correct. Only this statement is wrong. So the answer of this question is this one. So for great saphenous vein, whatever points we have discussed, all the points you should be knowing very well. And usually the question is focused on either of them. Right? Yeah. Medial aspect. Very correct. Kumar, Medico. Shanawaz, Ethik, yeah, saphenous opening 4 centimeter lateral, below and lateral. Okay, now let us come to this next question. Now what is this next question? Try to read this. A patient presents with complaint of headache, blurring of vision, and after the various investigations, we have understood it is meningioma. And now when we are performing the surgery of the meningioma, the paracentral lobule got injured. Now the key point is this one. This is a key point. Paracentral lobule is got injured. Now, whenever the word paracentral lobule is given, क्विकली यू शुड थिंक अबाउट व्हाट, जैसे पैरासेंट्रल लोब्यूल वर्ड आया सबसे पहले क्या सोचना है कि इट इज सप्लाइंग स्पेसिफिकली विच एरिया ऑफ द बॉडी, एंड इन दैट एरिया ऑफ द बॉडी the symptoms will be seen. Like it is written, this will lead to the parasis. Parasis means motor symptom. Not only the motor symptom, there will be motor symptoms as well as the sensory symptoms in that area. And yes, very, very correct, all of you. I can see all of you are answering. Priya, Yogesh, Himanshu, Khurshid, Mohan, Ankit, very good, very good, very good. Ambika. So the answer is C over here. Why? Because see, if the image is given to you, then also you should be able to identify this is what, this is the medial view of the cerebrum, and in the medial view this colored area is the location for paracentral lobule. Okay, if this image is given, you should be knowing it is paracentral lobule, and the paracentral lobule, it represents what? It represents perineum and lower limb. It represents both perineum and lower limb. So the sensory and the motor symptoms are seen in both the areas. Lower limb means thigh area also, leg area also, complete lower limb. And a very, very easy way to answer it, a very, very easy way. If you see the word paracentral lobule, P for paracentral, P for perineum. L for lobule, L for lower limb. So the other parts of the other regions of the body, U for upper limb, T for thorax, H for head and neck, all are having different alphabet. तो अगर आप alphabet देखोगे तो बड़ा easy हो जाएगा आंसर करना. P एक ही आएगा perineum, L से आएगा lower limb. So a very easy question in fact, and when you see, of course you know that it is affecting lower limb also. In this it is written not perineum, so this point is wrong over here, this point is wrong over here, and yes, involving perineum as well as leg. Yes, this is correct. And in the D option, thorax is not affected, leg and perineum. So therefore we say the answer of this question is what? Answer of this question is C. Yes, very, very correct. Lower limb, perineum. Yes, very correct. So this is the answer over here, C. Okay, now over here, let us see this question. The lesion of sensory area, it can lead to difficulty in perception of sensations. That is very much understood. If the sensory area is gone, of course the problem will be in the sensations. But now the point is that in which gyrus it is associated. You have to tell the location of the sensory area, that which gyrus it is located. Try to answer it. I hope that I'm not going fast. I'm a bit fast because I know that you all have studied and it should be a quick revision for you. And if there is any point which you think that you have maybe during this live class you heard it once and you want to hear it again, you can go back to that point again and you can hear, right? So yes, I can see you are answering B, and also answer is D, B or D. Okay, a lot of you are answering B, right? Krishna, Dr. Medico, Shivangin, Subhash, Bhargav, Mohan. Okay, very good. 312, very, very correct, Dr. Thakur. Dr. Shahnawaz, I'm actually taking the green tea because you can see my voice, थोड़ा सा बीच में voice गड़बड़ हो रही है, so that is why I have to take the green tea so that the throat is clear. And I usually prefer to take green tea because if I take tea and coffee a lot, that is a lot of caffeine, and that is why I also recommend everybody that take green tea. Less of caffeine is there, but yes, when you need caffeine to wake up yourself, तब तो आपको coffee चाय लेनी ही पड़ेगी. Very, very correct. The answer is B. Now, if you see the areas over here, this is the lateral view of the cerebrum, this is a medial view. Medial view we have understood already that this is the paracentral lobule, but when you go to the this lateral view, this is a central sulcus. In front of central sulcus, which area? Motor area. What is this? प्री-सेंट्रल गायरस. प्री-सेंट्रल गायरस मीन्स इन फ्रंट ऑफ सेंट्रल सल्कस. ठीक है, प्री-सेंट्रल का मतलब हो गया सेंट्रल सल्कस के आगे वाला. और जैसे मैंने कहा पोस्ट सेंट्रल मतलब सेंट्रल सल्कस के पोस्टीरियर साइड पे जो एरिया, उसके बिहाइंड जो है. सो दिस सेंसरी एरिया इज बिहाइंड द सेंट्रल सल्कस, सो द इट इज व्हाट, it is post central gyrus. Okay, it is a post central gyrus. So you can see over here, very correct, Dr. Daily Bread, it is a post central gyrus. Area number is 312 and this is the area which is affected. Okay, Shahnawaz, yeah. Shivangi, antioxidant, yes. So over here we have understood this point. Now when you see visual area, what is the location? Posterior side, occipital area. In the occipital lobe, the visual area is there. And if I look over here, auditory area and the Wernicke's sensory area. Now what is this location? Location, if you see, it is what? This is the temporal lobe. Okay, this is the temporal lobe. Which part of the temporal lobe? This is the superior part of the temporal lobe. So what will be the gyrus? Superior temporal gyrus for auditory area as well as this Wernicke's sensory speech area. And let us go to the Broca's. Broca's is left now. Broca's is present in this lobe, and when you see this whole lobe, what is this? This is the frontal lobe, and in the frontal lobe, it is present on the inferior side. So what will be the answer over here? This is what? Inferior frontal gyrus. It is a location of Broca's area. And definitely over here, this is a very important question, and they can ask you motor area, sensory area. At present, speech areas is the favorite for the examiner, but yes, you should be knowing about the other areas also. Right? If you remember this image, then you are able to correctly answer. You are able to correctly answer this question, and therefore the answer of this question is post-central gyrus. So you know कि if the motor area is affected, motor symptoms are there. If sensory area is affected, sensory symptom. Visual area, visual symptom. Auditory area affected, hearing symptom. Speech area affected, speaking symptoms are there. Thank you, Dr. Puneet. Thank you. Yes, Nabil, of course you will do very well. Okay, so now we have understood over here that the answer of this question is post-central, and I'm giving you one extra question. Okay, in these areas only, I'm giving you one extra question because the speech area is favorite for the examiner. We have understood the location of the speech areas. Wernicke's area number is 22, also 3940, but mainly it is 22. Broca's area number 44, 45. But over here, the clinical aspect. When you talk about the clinical aspect, if you read this question, patient is able to understand. Okay, he is able to understand and analyze. Yes, Dr. Nab, of course you will do really well. Yes, I can see you have started answering the question. Kumar B, Ritik A, Sameer, Aditya, Himanshu, Rashik, Ayushi, A, B. Yeah, actually there is a confusion between A and B. Because we know it is not motor and the sensory area, we have to decide between A and B. Patient is able to understand, but he is unable to express himself. He speaks only 2 or 3 words and he is unable to explain. Yes, very, very correct. It is the Broca's area which is affected over here, which leads to non-fluent aphasia. What is happening in the non-fluent aphasia? See, Wernicke's area is basically for understanding. When you talk about the Wernicke's area, it is for understanding. And Broca's area is for final speaking. So if I say the Broca's area is affected, Wernicke's area is okay, so he is able to understand. When you say able to understand means Wernicke's area is normal. It is normal because that is why he is able to understand, but unable to speak, unable to express. So that means which area is affected? It is Broca's area which is affected. And it leads to non-fluent aphasia. If I say Wernicke's area, what happens in the Wernicke's area? There is fluent aphasia. Fluent aphasia means the patient is not able to understand, and even then he keeps speaking. So that is what? That is the fluent aphasia. Yes, very correct. Now over here, yeah, very correct, Madhuri. She has told very interesting thing. Say right. Okay. Sorry. So now when we are talking about these areas, they can ask you which area is affected, or they can ask you which gyrus is affected. So now you know Broca's area, if it is affected, this is inferior frontal gyrus. If the Wernicke's area is affected, it is superior temporal gyrus. That we have already discussed. And any of the areas asked, if by chance you are having any problem in memorizing it. Yes, very correct MR, very correct Kumar, bol nahi sakta Broca. So if you are having, by chance you are having any problem in memorizing this aphasia, memorize one, Broca. And a Broca's, this is a aphasia, which is a viva aphasia. You know, like the condition when you're situation, exactly that situation when you are giving viva. तो viva में क्या होता है? Questions सारे समझ में आते हैं, but answer नहीं आता. You are not able to speak, you are not able to express yourself. You know each and every question. पढ़ा सब है, आता सब है. आप बोलोगे सर से कि सर मैंने पढ़ा तो है, but answer नहीं आता है. So same thing is happening over here. When you say viva is happening ना, you are able to understand every question, but you are not able to speak. You're not able to express. So you remember Broca is viva. It is a situation of viva. So Broca is viva. Okay. So just a viva kind situation means understanding everything and not able to speak. Just opposite of this happens in Wernicke's. So you can remember one thing, Broca as viva. If you remember this one thing, just opposite is the, just opposite is what? Is the Wernicke's. So over here the answer is Broca's area. Correct, Krishna. Correct. One of your friends has told a very interesting trick. Doctor has told very interesting trick. Broca means broken speech. है ना? Broca जैसे बोला तो Broca मतलब broken speech. मतलब वो ठीक से बोल नहीं पा रहा. Broken है. Okay, now let us see this question over here. डेली ब्रेड सही कहा ना मैंने, सही बात है ना. ब्रोका, ब्रोकन स्पीच तो ऑलरेडी उन्होंने बोल दिया. ब्रोकन स्पीच मतलब वाइवा नहीं दे पा रहा, वाइवा में ब्रोकन है बिल्कुल. तो ब्रोका कहते हैं ना, ब्रोकन इन वाइवा. Okay, so very correct over here. The joint shown in the image, it is helping to look on left side and then on the right side. Okay, just do like this, left side and then right side. You are seeing towards the left side, then towards the right side. Now what is this? This is the no movement. It is actually what? It is no movement. And when we are talking about the no movement, it actually occurs where it occurs at atlantoaxial joint. Very correct all of you. And this is a question where I can see everybody is answering correctly. No confusion is there, and very correct. Pivot joint. It is a pivot variety of synovial joint. Very correct. And if you see this image, now in this image, this ring shaped vertebra, it is C1, and this second vertebra over here is C2. And for the C2, you can see this projection over here, which is what? It is the odontoid process or the dens. So the image shown over here is the atlantoaxial joint. That is C1 is the atlas, C2 is axis. So the answer over here is joint between C1 and C2. Very correct. It is a pivot variety of synovial joint. Now, if you see this image, this is the posterior view of again the same thing. This is C1, this is C2. And when I say this is C1 and C2, the joint which is formed between them is which joint? It is atlantoaxial joint, which we have just mentioned that it is what? It is no movement joint. So like this question can be asked theoretically, or this question can be asked as an image based question. So you should be able to understand that that is atlantoaxial joint. Over here also C1 and C2, this joint is atlantoaxial joint. Now apart from this, just for your idea, one more thing I am saying, what is this? Skull. Okay, this is the skull, and in the skull most posterior bone is occipital bone. राइट. सबसे पोस्टीरियर यहाँ पे कौन सी है? occipital bone. Now when I say what is this joint, so now you know that this joint is between skull means occipital bone and atlas. So this joint is atlanto-occipital joint. So you should be able to differentiate between the two joints, and this is atlanto-occipital joint, which we basically say it is a yes movement joint. Yes movement is this, okay, when you're saying yes to someone. So this is the movement when you're doing slight flexion and slight extension, flexion, extension. So this is the yes movement, and for this atlanto-occipital joint. So basically we are memorizing this atlanto-occipital. ठीक है, याद हमें atlanto-occipital रखना है, because this is the one, sorry, we have to remember what? Atlanto-axial, not occipital, atlanto-axial. We are going to memorize this one because this is the most important joint over here, but we should be having an idea that other one is which one if the image based question is asked. So that is the atlanto-occipital, and this is a variety of ellipsoid actually, and that is opposite of it. It is a yes movement joint. Okay, this is ellipsoid. So this I'm just mentioning as a reference so that you are able to differentiate it, and finally the answer of this question is A. Yes, very correct, Bini. This kind of movement we need on result day. Everything happened correctly, just according to me. Yes, 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 yes for everything. And now this is a joint which is actually a very important joint, yet to be asked as a question, and you should be able to answer it correctly. This is a joint, this is an image in which there should not be any error. And when you see this image, you know that what is this? It is ear ossicles. Okay, it is the ear ossicles. So, yeah, so it is the ear ossicles. Try to answer this question that which, first of all, you have to identify the joint over here. Secondly, you have to tell it is which variety of the joint. Okay, which variety of the joint is this? So you very well know, like try to answer it B, A, D, again B, A. A lot of you are saying A, then B also. See, first of all, see what is this bone? This is malleus. Second is incus. This is stapes. Okay, these are the bones over here. This is the malleus, this is incus and stapes. So when I say arrow, arrow is between malleus and incus. So this is incudo. Incudo means incus, mallular means malleus. This is actually incudo-mallular joint. And now if I talk about this another joint, this is given the term as incudo-stapedial joint. It is the incudo-stapedial joint. Very, very correct, all of you. So incus and stapes, name of the joint is this. Malleus and incus, incudo-mallular. And now when you talk about this one, it is saddle variety of synovial joint. And when you talk about the another one, it is ball and socket variety of the synovial joint. Right. So now these are the two joints which you first of all should be able to understand that it is a joint between which ear ossicle, and if the image is given, then also you should be able to tell. Then we say what is the type of the joint. First is saddle, and the second is what? Second is ball and socket. So over here, the answer of the question will be what? So you know that incudo-mallular. It is not this one. So we have just excluded easily that C and D is not there, but we have to choose between what? A and B. One of your friend has told you a very easy trick. I am sad. M-I sad. Very interesting trick, Anuj. And yeah, Rashik also. Rashik, Anuj. Oh, they have told you very interesting thing. Very interesting. So in fact, you have helped us. I am sad. I am sad. I is incus, M is malleus, sad is saddle. So therefore now we say the answer of this question is what? The answer of this question is I am sad. So we are thankful to your friends. They have given you very interesting trick. Yeah, Miss Sad Balika. That is also a mnemonic to memorize. So I am sad means incus and malleus, between it is sad, saddle, and the other one is the ball and socket. So this question should be your scorer. इस क्वेश्चन में कोई भी गलती नहीं होनी चाहिए. अगर ये क्वेश्चन आ गया कोई भी गलती नहीं होनी चाहिए. So don't focus on the pain, focus on the progress, and that is true because at this moment of time you must be feeling that कैसी जिंदगी है. सबसे पहली चीज आपके दिमाग में आती है कि ये कैसी जिंदगी है. उठो, पढ़ाई करो, पढ़ाई ना करो तो टेंशन, पढ़ाई करो तो टेंशन कि ये पढ़ लिया बट वो नहीं पढ़ा, पूरे दिन टेंशन ही टेंशन, क्या जिंदगी है. सबसे पहले दिमाग में ये चीज आती है. सो डोंट फोकस ऑन द पेन, डोंट फोकस ऑन दिस problem which you are facing at present. Yes, of course you will be facing this things at this point of time, that a lot of anxiety, tension, doubts, a lot of things coming up your mind, but rather than focusing on that, focus on your progress. You have a brain, a human brain. You are not a robot. If I tell you study, so you are not a robot. While studying you will think a lot of things, क्योंकि ह्यूमन हो, सोचोगे 10 चीजें सोचोगे, रॉबर्ट थोड़ी ना हो. और क्योंकि सोच रहे हो तो अपनी सोच को आपको थोड़ा सा चैनलाइज करना है. 10 थॉट आ रहे दिमाग में, उनको समझाओ, अभी नहीं, मैं 1 महीने बाद सोचूंगा तुम्हारे बारे में. और 1 महीने बाद लिख लो कि भाई 1 महीने बाद मैं सब सोचूंगा, जो मुझे सोचना है, सारे डिस्ट्रैक्शंस जो भी है सब 1 महीने बाद. अभी मुझे फोकस करना है सिर्फ पढ़ाई पे. सो फोकस ऑन योर स्टडीज, फोकस ऑन योर प्रोग्रेस. लेट अस कम टू दिस नेक्स्ट क्वेश्चन ओवर हियर. अजय शर्मा सिंह, रूम में बंद रहो. डॉक्टर पुनीत, पढ़ाई करो तो ज़्यादा टेंशन, क्योंकि पढ़ाई करके भी टेस्ट में नंबर नहीं आ रहे हैं. ओ डोंट वरी. सी, the test is basically to assess that if you are able to properly study or not. The marks is actually not the criteria for that. There are chances that you may score less in the test, but when the exam is there you may score more, because usually what happens, like the main thing in the test is that those who score more, the point is that don't get relaxed. You have to maintain that pace. And those who score less, for them the advice is don't lose hope. You never know that you may cross 200 also. So when you are giving the test, कई बार होता है कि बड़े सारे नंबर आते हैं किसी के, ओवर कॉन्फिडेंस, उनको लगता है यार ये सब्जेक्ट तो मुझे आता है, उसको ठीक से रिवाइज नहीं करते. तो जब भी आप टेस्ट दे रहे हो, अच्छे नंबर आए या अच्छे नंबर ना आए, दोनों सिचुएशन में आपको थोड़ा सा केयरफुल रहना है. और अगर नंबर थोड़े कम भी आ रहे हैं, इनफैक्ट दो स्टूडेंट्स हु आर गेटिंग लेस मार्क्स, दे आर मोर मोटिवेटेड टू स्टडी. दे विल फील कि आई हैव नॉट डन दिस सब्जेक्ट, दे विल स्टडी मोर, and the chances are they can get good score also. Okay, so over here answer, let us see. The answer is, you can see this arrows over here and you have to tell that which statement is correct. मूडी मेडिको, आई नो कि ऐसा लगता है ऐसा हमें, बट हमें सोचना नहीं चाहिए. हमें यही सोचना चाहिए कि नहीं, वी आर वेरी गुड एंड वी आर एट अ वेरी गुड प्लेस. माना कि ऐसा लगता है टाइम बिंग कि अरे क्या जिंदगी है, बट एक्चुअली आप बहुत ही बढ़िया जगह पे हो. आप डॉक्टर बन ही चुके हो और डॉक्टर बनोगे. ऑफ कोर्स आप लोग डॉक्टर बनोगे. बहुत सारे ऐसे लोग हैं जिनके ड्रीम्स होते हैं डॉक्टर बनना, बट वो उनके ड्रीम पूरा नहीं हो पाता. बट आपका ड्रीम पूरा होने जा रहा है, क्योंकि लाइक आप डिफरेंट हो बाकी लोगों से. और आप कहते हैं ना कि हम लक्की नहीं, अरे आप लक्की हो, आप डॉक्टर बन गए. इतनी जनता है जो डॉक्टर बनना चाहती है, नहीं बन पाती. सो कंसिडर योरसेल्फ लकी एंड टेक, यू नो, जस्ट कहते हैं ना कि कोई चीज नहीं मिलती तो आप जिद कर लेते हो कि नहीं मुझे चाहिए. तो ऐसे ही जो डॉक्टर का टाइटल है ना, जिद कर लो कि ये तो मेरा ही है, मुझे चाहिए, और आपको मिलके रहेगा. ओके, सो ओवर हियर लेट अस क्विकली discuss this question. Over here we have put arrow. This is the sagittal section of head and neck, and we have focused towards the lower side of the head and neck, towards the larynx area. When you see A structure, this is what, this is a projection over here, a projecting part over here. And what is this? This is epiglottis. This is the epiglottis. What is B? B is this structure. This is the section of thyroid cartilage, which is a V-shaped cartilage, or you say open book cartilage. And if I say open book or V-shape, it is like this. It covers the larynx in this way. So that is why thyroid cartilage is present on the anterior side and lateral side, but not on the posterior side. So therefore, no section is seen towards the posterior aspect of larynx, only on the anterior side. So this is a complete larynx. Now next is C. C is what? this portion, and the C is cricoid cartilage. Now, because the cricoid cartilage is a ring-shaped cartilage, and if I say ring-shaped cartilage, you do the sagittal section. So, because it is ring-shaped, section is seen towards the anterior side also, section is seen towards the posterior side also. And similarly, I will just focus over here. This is the cricoid cartilage in the blue color. This is the cricoid cartilage, and towards the posterior side also, this section which you see over here, this is also cricoid cartilage because it is a ring-shaped cartilage. तो रिंग शेप्ड है तो थोड़ा सा सेक्शन एंटीरियर साइड पे दिख रहा है, थोड़ा सा सेक्शन पोस्टीरियर साइड पे दिख रहा है. सो दिस इज व्हाट इट इज, cricoid cartilage. If arrow is over here or arrow is over here, you should be able to tell this is cricoid. And then lastly, the D over here, D is this small bony structure which is present over here. And what we say, this bony structure is what? It is the hide bone. So we have completely understood this area over here. And hide is a bone. All these are the main cartilages. Just for your knowledge, I will say epiglottis is elastic cartilage, and when you talk about the other two, they are hyaline cartilage, right? They are the hyaline cartilage. So now let us go to the question over here. What is this? Arrow A is vallicular. No, it is not vallicular. Vallicular is what? Vallicular is this depression, which is basically between this tongue and epiglottis. So between the tongue and epiglottis, this depression over here is vallicular. So this is not true. Arrow B is epiglottis. This is also not true because this is thyroid cartilage. C is cricoid. Very correct. D is not thyroid cartilage. It is hide bone. So over here we say the answer is C. Oh, that's great, Moody Medico. Definitely you will clear this exam. My best wishes are with you. In fact, the best wishes with all of the students that you clear this exam, and I will also definitely wait to meet you all. Okay, now let us go to this next question. And now in this question, this is also a question which we cannot miss. And over here, this should be our scorer. अगर ये question आ गया तो टेंशन नहीं होनी चाहिए. ऐसा नहीं होना चाहिए कि सिली मिस्टेक हो. ये लगना चाहिए कि अरे वाह, ये क्वेश्चन आ गया, बहुत ही बढ़िया. तो ऐसी फीलिंग होनी चाहिए. एंड यू शुड बी वेरी मच क्लियर दैट व्हाट आर दीज स्ट्रक्चर्स. सो ओवर हियर ask. Okay, ask. Oh, that's great. That's great, dear. You cleared by 196. Very, very good. Very, very good. Thanks, dear. Dr. Puneet. Okay. Very, very correct. You have to choose correct statement. Okay. Now, what is A? Like, let us just go through the statements and let us try to read it. Again, congratulations to you, Ask. Very, very, yeah, this question was actually asked in the July 24, this July exam, but the question was not like this. It was a direct question. It was a direct question. Only one arrow was put, and one arrow was put on lienorenal ligament. But over here, we are covering all the arrows because we should be aware of all the structures. Now, when you see this image, you know very well, this is the liver, stomach, and this is the spleen. Fine. When you see over here, posteriorly it is the vertebra. This is the right kidney. This is the left kidney. In front of it, this is the aorta, descending aorta. And this structure is inferior vena cava. So these are the major structures over here. And now when you talk about A and B, A is what? A is between what? Just see over here, it is between stomach and spleen. Yes, Shahnawaz, why not? Why not? यहाँ पे हम कोई डिस्टिंक्शन नहीं रखते कि मिस्ड या हमारा नॉन मिस्टियन स्टूडेंट है. ऑल द स्टूडेंट्स आर सेम फॉर अस. यू आर ऑलवेज वेलकम. Always welcome. We will eagerly meet with you. We will be eagerly waiting. So yes, do welcome, and I really want that you clear this exam and you come over here and we will celebrate your victory. So over here, between the stomach and spleen, if it is the word is there, what is this? Gastro. Gastro means stomach. Spleen means splenic. It is a gastrosplenic ligament. And when you see another one, what is that? This is between spleen and kidney. What can be the answer? Spleno means spleen. kidney, renal. So this is actually splenorenal ligament, and this is a ligament which is very, very important, favorite of the examiner right now. It is also given the term as linorenal ligament. Same thing, it is also given the term as linorenal ligament. And over here we say, what is the content of this? The content over here is splenic vessels. Splenic vessels means artery and the vein both. Okay, you very well know artery and the vein both, as well as what? Tail of pancreas. In the pancreas, which part? Tail. So these are the major contents over here, and question can be asked on this ligament, or the question can be asked on this contents. Very, very important structure, but you should be able to differentiate it from gastrosplenic. Then if I come over here, C and D, it is the arrow on, both are the arrow on lesser omentum. This complete structure over here is lesser omentum, which is from the liver to the stomach, right? Both are the arrow on the lesser omentum, but when you see over here, this is the arrow near the stomach, and some vessels are seen over here near the stomach. What is it? It is gastric vessels. And very easy way to remember it, if it is near the stomach, the structures of stomach only, gastric vessels. And on the other side over here, the arrow is over here, which is having small sections, and it is towards the liver. So the structures of liver, which is portal triad, it is a portal triad. तो जो stomach के पास है वो gastric वाले structures हो गए, जो liver के पास है वो liver वाले structures हो गए, portal triad. और जो arrow है पूरा, अगर हम देखेंगे पूरा जो है ये lesser omentum है. So now definitely we know the answer of this question. Yes, very correct all of you. I can see that you have answered it. Ayushi, Namrata, Medico, Aliyavar. Ayushi, very correct. Nabil, yes. I will eagerly wait for that. Nabil. Yeah, portal triad. Dr. Shriyashi, yes. I hope you are also good. I am fine. I am also good. Yes, very good, very good. And now we know A is not splenorenal, it is gastrosplenic. B is correct. C is not having splenic vessels, it is having gastric vessels. D is lesser omentum, and we very well are able to answer this question. And this question is basically to understand each and every aspect over here so that there is no error. ठीक है, इस वाले क्वेश्चन में कोई भी एरर नहीं होनी चाहिए, कोई कंफ्यूजन नहीं होनी चाहिए. अगर जैसे ये क्वेश्चन आए फटाफट आपको पता होना चाहिए भी कौन सा लिगामेंट या ओमेंटम कहाँ पर है और which are the components over there. So now coming to this last question over here, and I hope that we are able to revise a lot of important topics and all the high yield topics which are very, very important for your recent exam, which is on the 12th January. And in this short duration of time, we have actually covered a lot of points. So now coming to this last question, this is what is true about the arrow marked structure. Now what is this? This is the heart. Arrow is over here. Okay, arrow is over here, and you have to find the true statement. I will zoom this image. Try to answer it. B, C, A. You have to find the true statement. B, C, B, C means like there is a confusion between B and C. B and C. Okay. Okay, confusion between B and C. So that means there is no confusion between A and D. And yes, very correct, Aditya. This is what? This is the right coronary artery. So let us see over here. What is this? This is the anterior view of the heart. And when you see the anterior view of the heart, the arrow over here is on this artery. And this artery is right coronary artery. Okay, this artery is the right coronary artery. When you see another artery over here at this location, this is a very small artery which is left coronary artery. And when you are talking about the left coronary artery, quickly it divides into branches. One branch is going like this. This is one branch which is running downwards. Another branch is taking a turn like this. So when you see this branch of left coronary artery which is running downwards, means descending downwards. ठीक है, जैसे आप ये branch देखोगे ऐसा लगेगा कि it is running downwards, descending downwards. What is this? This is the descending artery. Because it is descending on the anterior side, anterior descending artery. Because it is a branch of left anterior descending. तो left side से आ रही है, anterior side पर है, running downwards, descending downwards. This is left anterior descending artery, which is also given the term as anterior interventricular artery. ठीक है, anterior side पे है, it is on the anterior side, it is between the two ventricles, so given the term as anterior interventricular artery. The another branch is this one, which is taking a turn and going backwards. Because it is taking a turn, it is termed as circumflex. Because it is arising from left side, it is termed as left circumflex. Fine. So these are the two main branches of left coronary. And if you say which is the main branch of right, main branch of right is PIVA. PIVA is posterior interventricular artery. So as the name suggests, posterior, it will be present on the posterior side. You cannot see it on the anterior side. If you see this image, these are the main arteries which you are able to visualize. Okay, so now over here we mentioned the branches. One more thing is there. Right coronary artery, it arises from where? It arises from anterior aortic sinus. Aortic sinus of what? Ascending aorta. Yes, it is arising from anterior aortic sinus of ascending aorta. The ascending aorta is having 3 aortic sinus, 1 anterior, 2 posterior. And now when you say anterior is for right coronary, what about the left? Left arises from left posterior aortic sinus, again of ascending aorta. Again of the ascending aorta. So ascending aorta is having this aortic sinus, and now we have understood the origin of the arteries as well as the branches we can identify in the image also. Let us go back to the question. We have to find the true statement. If it is written anterior interventricular artery, it is not a branch of right coronary artery. Arrow is on right coronary. It is actually a branch of left coronary. Similarly, this branch is also, it is branch of left coronary. And see, there is no scope for any confusion, because when you say left coronary, left for left. So left, already word left means it is coming from the left coronary. Third arises from anterior aortic sinus. This is correct. And when you talk about the fourth one, it is actually the origin for left coronary. So therefore the answer of this question is what? Answer of this question is C. The true statement is it arises from anterior aortic sinus. That is the correct answer. Okay, so I hope that you have now understood. Yeah, Namrata and Subhash, pica is for circular villus. We are talking about PIVA, posterior interventricular artery. So now finally answer is what? Finally the answer is C. So over here we have basically understood origins of the two main coronary arteries. We have understood the main branches, and now we can identify the branches in the image also. Okay, I know that by mistake you must have written pica. So the answer over here is this artery. And now quickly I will discuss few more points which are like very high yield points, and we cannot leave those high yield points because we were making 25 questions, and you can see we have discussed few extra questions also. So now quickly I am going through this. Superior gluteal nerve injury, very important nerve injury. This is what? This is Trendelenburg's sign, and if this is there, it is a superior gluteal nerve injury, medius minimus paralyzed. Whenever medius minimus paralyzed means abduction at hip joint, it is affected. So it actually involves the abduction, or there will be problem in the abduction at the hip joint. Pelvis sag to which side? Opposite side. Trendelenburg's sign is positive and the lurching gait is there. So very important point. All the 3 points over here, the first, second, third, and this identification of the image, it is very important for you. And yes, this image is what? It is drop shoulder. Which nerve injury? It is spinal accessory nerve injury. And whenever spinal accessory nerve injury is there, what happens? Due to trapezius paralysis, loss of shrugging and as well as drop shoulder, and due to the sternocleidomastoid, difficulty in turning the head or neck. Okay, Pushpa. So Pushpa 2 to just it released now. So you know what Pushpa 1? Pushpa 1 was like this. So what was that? Dropped shoulder. So dropped shoulder, Pushpa movie, spinal accessory nerve. Yes, this table you cannot miss. This is what esophageal constrictions, and over here location you should be knowing, and apart from location, distance from incisor teeth specifically in centimeter. You should be knowing that. Okay, over here I'm just removing this. You have to follow 15, 23, 28, 40. Then when you talk about the pterion, a very, very important landmark, you should be able to answer middle meningeal artery deep to it. And what other structure? Stem of the lateral sulcus of what? Cerebral hemisphere. Stem of lateral sulcus. Lumbar puncture, what is there? Over here, they usually ask you the question on the layers pierced, in which 3 ligaments are this, which are from outer to inner. So it is supraspinous, interspinous ligamentum flavum, another structure, which meninges are pierced, dura and the arachnoid. What is the last structure pierced? Arachnoid. So this is for lumbar puncture. And by this we have finished the session, and Krishna, thanks. Oh, that's great. That's great that you are feeling confident, and thanks to all of you also for actively participating in the session and trying to answer it. So your effort actually matters. So thank you, Nabil. That's great. ओह प्रियंका, ब्रेक में रेस्ट करना, ब्रेक में माइंड को रिलैक्स रखना, जब पेपर पूरा हो जाए तब याद करना मुझे. Okay, that's great, that's great. Okay, so we have done, yeah, PDF we will, of course, in this YouTube session, we will put the link for the PDF so that you can download it. Just give some time for that. Within few hours, the PDF will be uploaded. Okay, so that's great. Daily Bread, thank you. Yes, Bhargav. Yes, yes. I'm also eagerly waiting to meet you all. So thank you, all of you. Okay, that's good, Anuj, that you are feeling good. And yes, Kamal Kant. Yeah, very good, very good. Namrata, and thank you to all of you. Thank you to all of you. That's great. And definitely, like you were saying, ma'am, a high yield session takes one more high yield session. So yes, I will be taking a small session later on, the rapid image revision session, so that that will be very helpful just before the exam. We will be having a rapid image revision also. So thank you to all of you. Ajay Sharma, you are saying? Oh, oh, very good. Yes, Krishna. Yes, Krishna. Thanks, Dr. Rahul, Runa, everybody, thank you. Yes, Prashant, yes, we will pass. We will pass, we can do it, and we will be able to do it. Focus on progress only, focus on your studies only. So best wishes to all of you, best of luck to all of you. So by this, yes, Prashant, ab ki baar 200 par, bilkul correct. Ab ki baar 200 par. Phoenix, yeah, Phoenix, Madhuri. So by this, I will be ending the session. I will not take much time of yours, and we have finished the session in 2.5 hours. We have been a bit quick. You are saying, Chavan. Okay, that's great. Thank you to all of you. Target 280% हो गया. Very good. Yes, 20% images से भी हो जाएगा. Very correct. So I will be ending the session now. I will not take much time because your time is very precious. You can, you already have attended 2.5 hour session. Now you can relax for a while. And after that, you can just quickly see those points again in which you are slightly confused, or the points where you are not able to memorize. You can quickly see that points today only. That will not take much time, but see that specific points only. Okay, don't see the whole video. The whole video you have already seen, but now focus on the specific points. So thank you to all of you. Thanks, Duman Sahu. Thanks, Alan. Thank you. So thanks to all of you. Prashant, Krishna, Naresh, Nabil. Thank you to all of you. Okay, so bye to all of you. Best of luck from my side, from the whole MIST team, all the faculties of MIST team. So best of luck to all of you. And by this, I'm ending the session, and